Okay, thanks everyone, and welcome to the PPM working group meeting. I now turn the floor over to Dr. Teresa Kasaeva, Director of WHO's Global TB Program, and Dr. Madhu Pai, Chair of the PPM working group.
Thank you. Thank you very much, Monica. Dear distinguished colleagues, partners, and friends, warm greetings from Geneva. I am Dr. Teresa Kasaeva, Director of the WHO Global Tuberculosis Program. And I'm very pleased to welcome you today to this very important global meeting of the Working Group on Public-Private Mix for TB Care and Prevention. I'm happy today to join my distinguished colleague and friend, Chair of the Working Group, Dr. Madhu Pai, and a distinguished lineup of speakers today. I am sure that this will be a very important forum and successful meeting. We're looking forward to hear from you your advice, how we can all together manage in this very, very challenging time, how we should move forward and provide continuation of the essential services and in general progress towards our ambitious targets. This is 15th meeting of the working group. It was established in 2002. And many important activities were facilitated and initiated by this working group. And we have a roadmap with the clear priority activities. And today will be opportunity to overview the progress towards our agreed priorities. And of course, we will look all together to the progress according to our NTB strategy targets from the political declaration and other priorities. Unfortunately, this is a very challenging time for the world. We are like in the middle of the biggest pandemic. It's new threat. And I would like to acknowledge and applaud to all your hard work and efforts you are doing, not only to provide TB services, to attract attention to TB, but also you involved, I know, heavily into the COVID response. And of course, we should think also and to thank all the health workers, community health workers, nurses working at the first front of the fight against COVID and TB. If we'll look at the progress to date, actually all the life divided into two parts, before COVID and now during COVID, we can't say after, still because the perspectives of the continuation are still not quite clear. But before COVID, we were able to collect data, information, and to review the progress. We've definitely made progress altogether. It's a result of the joint efforts, first of all, the countries and all the partner stakeholders, civil society, of course, and there were progress towards the targets, but it was not sufficient. Even if we are looking at our NTB strategy milestones, we didn't reach globally these milestones, but more positively, we can see in many high TB burden countries, the progress was especially impressive. And it shows us that it's possible, and some countries even reached milestones, high burden countries, and we should altogether look carefully at the examples, at the practices, and learn how it was possible. In terms of this specific topic of public-private engagement and engagement of all care providers, we can see again some progress, but still the biggest number of missing people, underreported people are in the countries with the huge private sector. And it means that we should be more focused on the engagement of private providers. And now during COVID, with the restrictions and lockdowns, again, this sector was impacted heavily. And what should be new approaches, new principles of our work? We should discuss all together and to agree. We have different forums, different platforms where we're trying to brainstorm, to understand. And I think with this excellent round of experts, program heads of programs, civil society, we will definitely find some better solutions, and will be able to provide some recommendations and guidance. Business as usual cannot work in the current situation, and as you could see, WHO already released some interim guidance which are focusing on the home-based treatment, on the delivery of the adequate drug stocks at home, more active use of digital technologies, including also for the reporting, and all other new well-known approaches, but still that are not in place everywhere. So I think that there is no need for me right now to go into the details. I wish all of you and us all successful and impactful meeting. And with this, I would like to give floor to my very good colleague and friend, Dr. Madhukar Pai, for his introductory remarks. Thank you.
Thank you, Teresa, and thank you, colleagues, for joining us. We are in a crisis for TB as a whole, and TB PPM is a subset of that. So if TB is suffering, TB PPM is equally suffering. And I think the private health sector itself is suffering. Just like many businesses and restaurants that we know are all closed now or have never recovered from the shock of this crisis, it's possible that many private health facilities might shut for forever or might not function well. And there have been clear trends, which we will talk about later, maybe on Wednesday, on how the private health sector has been badly impacted, maybe in some situations positively impacted. Bad impacts that we are starting to see and we will learn is, for example, cost of care is going up in the private health sector. And that is really bad news for TB, because we know TB affects the poorest, and therefore increasing cost of care cannot be a good thing at all from our perspective. The sector itself is shrinking, and that can be a big issue. And lastly, in terms of adaptations, which might be positive, I think private providers have had no choice but to adapt using telemedicine, WhatsApp consultations, home delivery of medicines. They're trying everything possible to just hang on in there and just survive and ride out this crisis. And that some of that might really be good for TB. So I think it'll be good to use these 2 days to really understand what has changed on the ground vis-a-vis the private health sector in general, what implications does it have for us in TB, and what can we do to bring back private sector to where we were, say, during the Jakarta meeting last year, where we ended on a very hopeful high note, thinking that things are getting better, notifications were going up, and then suddenly we've had this massive drop in notifications everywhere. I do worry a lot about what an average typical TB patient will do now in these countries with large private sectors. They go to the public sector is still swamped with COVID. Absolutely swamped with COVID, and they're terrified of going there for the fear of getting COVID. And they are worried about going to private health sector because the sector is shrunk and become more expensive. Where will they go now? Will they end up going to pharmacies and informal sector? These are all anxieties that we have that we need to really collect data and get smarter about. And then lastly, catching up on the millions of people we have missed even during this calendar year is a massive exercise. I mean, India alone has missed more than 500,000 people in the first 6 to 8 months. Where are they? How do we find them again? How do we get them back on treatment? And is it possible to do catch up without engaging the private sector in countries like India or Pakistan, Bangladesh, Indonesia, Philippines, Nigeria? what is our catch-up plan and where do private providers figure in our catch-up plan is something that I would like us to discuss during this period. So thank you so much again to all the speakers and the participants. I'll now hand you back to Monica for the next section.
So thanks so much, Madhu, and thanks to Teresa. You've already got a bit of a little flavor of what you can expect in the coming days. So we'd like to start with, of course, the heart of the issue, why we're all working on this important area of public-private mix or public-private collaboration. It's those who are affected, the survivors, those who are struggling with TB day in and day out. So I would like to now invite our next speaker in this opening panel, Funke Dusumu. She is a TB survivor from Nigeria, who we personally met. Both Teresa and I met her in Abuja during our high-level mission on TB and NCDs earlier this year in February, just before the lockdown. And Funke, thank you for joining us and for sharing your story. The floor is now yours.
Okay. Thank you very much for the opportunity. My name is Funke Dosumu, a health educator, a TB survivor, and a TB advocate. I survived tuberculosis in the year 2015. On February 2015, I started coughing. I thought it was a minor cough. I was treating it. At first, I assessed the pharmacy, which I thought was a normal cough. Then after 2 weeks, the cough persisted and was serious. So I went to a private hospital for proper treatment and checkup. Immediately, I was told to run some tests, got the result. I was told it's tuberculosis, the disease of the lungs. At first, I was afraid and that how could this be? But later, I summoned the courage to go through every bit of the process. And I had the courage that definitely I'll come out of it. I was placed on routine drugs, which I had to take every day for more than 6 months. During this process, I lost my weight due to loss of appetite, night sweat, fever, chest pain. I was isolated from my immediate environment, family, and children for some months to face my health squarely and also prevent this disease from spreading. I was undertaking some serious nutritional meal to help the drugs work adequately and to get my feet back. During this time, I couldn't walk, eat, bathe myself. All I could do was read, try to eat, take the drugs, go for my checkups and pray. My strength, courage, and motivation was from my family, who gave me the utmost support, even though we couldn't relate as usual. It was during this time I had the courage to help others from being stigmatized by the disease, tuberculosis that is curable and preventable. I went for my last checkup on December 2015, which came out negative. And at that process, I was able to stand up to my feet to make myself readily available for meetings, research, and interviews to speak about my experience, because I believe my story will always be an inspiration for someone out there. So I spoke louder than TB, yeah. Even though I lost my job in the process of the illness, I still have hope and standing strong to help others from death. I was able to build my skills around my artistic skills and motivation. So no barrier or limitation in the face of stigma and discrimination, just pushing ahead. So in addition to this, for us to get more cases, most people will not want to go to government hospitals, and then the private hospital is where people go for more treatment due to population. The private sector is unequipped in this aspect to diagnose or even to treat for TB. And so few of them patient that wants to do will want to be exploited the patient for treatment, thereby causing people to run away and prefer to do their own personal medication, equally worsening the spread of TB. I assess care in the private sector and the need for greater public private sector collaboration so that people affected by TB such as me, are able to access quality care, the latest drugs and diagnostic without heavy financial burden. So through developing myself in area of research to provide possible solutions to some of the challenges faced by our public-private sector on how to ending TB has made me realize that most private hospitals undergo serious challenges in the course of diagnosis, which still stand as a gap in assessing TB care, prevention, and treatment. There has to be a counseling of TB patients at the cost of treatment, feedback follow-up call to TB patients on continued treatment. There has to be a proper consultation in sample delivery for laboratory checks, adequate implementation of funds to TB program so as to improve TB care, prevention, and treatment. Some private hospitals still collect money for TB tests when we actually said that TB test is free. Transported TB samples are being charged on patients who come for TB tests. Ending TB in Nigeria is still a round circle due to unstable program meant to be focused on to ending TB once and for all. Why is COVID-19 having more edges than TB? And they almost have similar signs and symptoms. TB has been there for ages. We must have a stable program for TB if there has to be a way forward. And this can also start by appropriate delivery of sample and data collection. There's also a need for stakeholders to be carried along the TB program through forum with laboratorians, private clinics to figure their challenges. The pharmacy vendors, meeting them directly, not representative this time. Generating a questionnaire to move from laboratories to laboratories and formulate a question for data process. This will help the WHO or UN to formulate a policy or program from it and to also see what will happen next. The sputum samples are at a high risk due to COVID-19. Laboratorians are even much more exposed to COVID-19 samples. When patients cough out, sputum samples are brought to the lab. They are not only exposed to TB, but COVID-19 samples. There is still a lack of adequate gene expert facilities. Diagnostic centers are not evenly distributed, not situated even close to some communities. Caregivers like the pharmacy, private clinics who see more of these private patients have little or no knowledge on what to do when giving care due to lack of enlightenment and how to go about care and treatment. Rather, they look for ways to sell in their drugs. When given adequate information, this caregiver has the responsibility of referring patients to hospitals for immediate diagnosis and proper treatment when TB is identified. There is need to equip them with incentive on how to isolate these TB patients to get their sample immediately and move them for treatment. There's also a need to apply systematic approach so the program will not be hijacked by people who have ulterior motives. Thorough grassroots dissemination of information. Due to COVID-19, people will not want to visit the hospitals, afraid of being stigmatized. Raising awareness, especially to the grassroots, will help the gaps. Inappropriate medical practice contributes to unnecessary suffering for patients, diagnostic delays, continuous spread of TB, high health care cost of patients, the society, and development of MDR TBs. Finally, there has to be a separate plan on how to involve every pharmacy, public or private clinic to collaborate with themselves and also giving them something like an incentive, pushing them towards this drive. Together we can end TB. Thank you very much.
Thank you so much, Funke. That was really a very passionate call to action. And, you're no longer just a survivor. You're really a passionate advocate. You're a change maker. Thank you so much for highlighting these key gaps also now with COVID. You've really set the tone for the meeting. Thank you for joining us, and we hope
Thank you very much.
that through these discussions that you share your perspectives and so that we can strengthen our discussions. Thank you so very much.
Thank you.
Thank you, Funke. Now we will turn to our key stakeholders and partners to hear their perspectives. I would like to start by inviting Dr. William Wells, Senior TB Advisor from the U.S. Agency for International Development, USAID, the biggest bilateral donor for TB and the biggest supporter of PPM efforts worldwide for more than decades, I think. William is co-vice chair of the PPM working group. Over to you, William.
Thank you so much, Monica, and thanks very much to the PPM working group and WHO for organizing this important meeting. Many speakers thus far have already talked about the impact of COVID in terms of actually people reaching treatment. I think COVID has really exposed some of the gaps that we kind of knew were there in terms of reaching universal health coverage, but really exaggerated them and made them more clear. I think it's clearer than ever that we need public and private sector to be working at full steam ahead and in full cooperation in order to actually have a coherent health response. And that's what this group is about. And I think TB should be proud of the fact that this community has really led the way in many ways in taking a very organized response to this challenge. Other health areas have maybe, focused on getting out individual commodities, etc. We have the challenge of really having a whole of health system response. We've got a complicated diagnostic and treatment pathway that requires a coordination across many different care providers, which Funke so nicely outlined. So that's our challenge, but also it's our blessing in a way that if we can solve it, then it can be solved in general. As Monica mentioned, USAID has been a very long-term supporter of private provider engagement. We see it as a critical strategy. And I think there's increasing attention to responding to this at scale and again, really thinking about this in a very coordinated way. So I think you'll see that in the next couple of days, that we're really discussing this in a more organized and structural way, and not just focusing on a small project here, a small project there. So I think that's a very encouraging sign. So I just want to thank everyone again for joining. I think we've got a good, great day today and also on Wednesday, and looking forward to hearing everyone's inputs. Thank you so much.
Thanks so much, William. I now turn to Dr. Lal Sadasivan. He is co-vice chair of the PPM working group and is also now leading efforts in the political front, especially in Kerala, on health. So really good to have you, Lal. The floor is yours.
Thank you, Monica. Dear PPM colleagues, as many of us know, this is for the first time in the past 18 years since the formation of PPM working group that we are meeting remotely. We are in a different world, and we are learning and adapting to the new normal. And however, it is very satisfying to see large numbers of PPM practitioners and advocates joining this working group. While we still worry about the missing 3 million TB cases and express our concerns about the gaps in private sector engagement, my memory actually goes back to the PPM working group meeting in 2004 held in New Delhi. That was the first time I attended this working group. In that meeting, I can recollect our major concerns were how to define the private P part of the PPM, how to communicate with the private sector, and how to start surveillance in the private sector. So those were the fundamental issues in that meeting. Now, after 18 years, we are reviewing the global, regional, and national progress in prioritizing PPM to close the gaps in high burden TB countries. So we are discussing the progress in rolling out PPM roadmap towards global NTB targets. So from the days when we did not have a proper definition for the private sector, we have reached the days when we discuss the impact of the new COVID-19 pandemic on PPM that we have built so far. So this is where we stand now. And we have made a lot of progress in PPM in the past years, but we are struggling in front of a new and unexpected pandemic. COVID has the potential to upset a lot of progress. It has already done the progress that we have made in PPM to contribute to the efforts of ending TB. At the same time, like any other calamity, COVID is also making us think innovatively. this disaster is also presenting new opportunities before us. Even this meeting is a reflection of our innovative thinking and our diligent efforts to continue the fight against TB. Many of you remember earlier we were taught to advise TB patients to wear masks and advise health workers not to wear masks due to different reasons, medical as well as social reasons. In my country, police used to look with suspicion at people who wore masks in public places. Today, people can be chased by police if they don't wear a mask. So similarly, treatment supervision of each dose by a door provider was the norm in many countries, including my country. Now we are teaching all people about social distancing. We are teaching patients also about social distancing. So new normal is a reality in front of PPM also. We need to shape our PPM also to adapt to the new normal. As a senior member of this working group, I would like to thank WHO, Stop TB, USAID, Global Fund, BMGF, and other technical partners and donor organizations for all the great support and guidance that they have extended to us in the past 2 decades. I would also like to thank Dr. Teresa and Dr. Monica, and also welcome all the attendees to this attendees of this working group meeting. Thank you.
Thanks so much, Lal, for your intervention, and also for kind of going back a little bit on the history. You've been one of the oldest PPM working group members, I think, along with William, Madhu, and others. Thanks for that. I would now like to invite Dr. Mohammad Yassin from the Global Fund, the world's biggest international donor for TB, which also, by the way, the Global Fund has been quite instrumental in the past few years for the push to reach the missing millions through the strategic initiative. And we've seen really a push, a driving up of notifications. So we're very happy to have Mohammed here, who's also part of the PPM core group. So the floor is yours, Mohammed.
Thank you, Monica. Good morning, good afternoon, good evening, everyone. Thanks very much for the opportunity and organizing this meeting, WHO and the PPM working group. It's a pleasure to work with all of you. I just want to give you a few highlights about the overall Global Fund investment. I'll come back to the COVID and the impact of COVID and what the Global Fund is really contributing towards addressing the COVID-related issue and mitigating the risk of COVID on TB. Global Fund, as Monica said, a major international source of funding for TB, has been contributing to saving lives and supporting access to TB diagnosis and treatment. But the greatest momentum we consider as part of addressing the millions missing has been supported as part of the catalytic funding, where we would like to incentivize countries to move to more innovative approach and actually identifying those missing people, who are they and where are they missed. And that's where the relevance of the importance of private sector came in. And because most of people who are missing are probably accessing TB service in private sectors in several countries. But we are not very sure about the quality of service provided there, and we are not engaging them. That has been a missed opportunity. But during the last 3 years, as part of the catalytic or the matching funding and a strategic initiative working with WHO, Stop TB, and other partners, Global Fund has been contributing on the effort in finding the missing case in 13 countries. But that initiative has been successful and will be expanded to 20 countries in the next funding cycle. As you all may know, that more than 95% of the funding request for the next 3 years has already been submitted and reviewed by our technical review panel until this month. This is despite all this, the disruptions and the lockdown is COVID, and we are really positively surprised that the countries and partners managed to submit a good quality funding request, where we also have seen an alternative approach coming in, due to disruptions, and countries are looking other ways of implementing TB, including focusing more on communities, private sector, and that's where there's already opportunities. We have already seen in the Global Fund request where the PPM investment increased from 3% in the previous funding model to about 15% in the new funding model. That trend is also, gradually expanding, and more implementers and directly receiving funding from Global Fund are implementing private sector activities, and that trend would continue. And the matching funding and finding the missing millions would continue and expand it to other countries, which contribute to a majority of the missing case. One important point is really the impact of COVID and how to address it. As you may know, Global Fund already allocated $1 billion to address COVID and to mitigate the impact of COVID on the 3 disease. That's another opportunity to address some of the issues coming in as part of grant flexibility and as part of COVID response mechanisms, where countries have already accessed more than $800 million. That with a quick review and deployment approval of the funding request, that contributes just on top of what the countries requested as allocation. As Madhu earlier said, that we will have more assignment now. We are, due to the lockdown and COVID, we will be missing more TB patients. We already have heard a lot of disruption in many countries. So going forward, the next year is not only to really reach the 2021 target, it's really more about catching up the loss in 2020 as well. That's very critical. And Global Fund, we worked closely with all the partners and develop information note to support that catch-up plan. That is already in our website, and we all are looking forward to continue working together. And the private sector engagement, innovations, all this would help to address those gaps in finding the TB and treating them. And we all look forward to work closely with the partners and with countries as well to make sure that resources are available to promote and implement innovative approach and improve overall TB implementation, as business as usual is not going to really work in the future. Thank you very much again.
Thank you so much, Mohammad, and also thank you for sharing some of the forward-looking perspectives. In terms of what financing, what's available, and also the issues around COVID and how it's going to be a game changer moving ahead. I would now like to invite Jacob Cresswell, who heads TB Reach in the Stop TB Partnership. The PPM working group is a Stop TB Partnership working group. And we are very pleased to have you here, Jacob. Thank you for joining, and look forward to hearing your perspectives and work, especially through the funding of innovations through TB Reach. So look forward to hearing from you. The floor is yours.
Thank you, Monica, and welcome everybody. As Monica mentioned, of all of the working groups that Stop TB hosts, I really enjoy every year coming to seeing you all in person, this time virtually. So it's great to talk about all of the advancements and hear from you all. And at Stop TB and TB Reach specifically, we've been supporting different models of private sector engagement since TB Reach launched back in 2010. We've funded more than 70 grants to different NGO and NTP partners in many different ways of engaging private providers, many different types of private providers, all looking to improve case detection. And Mohammed and others have mentioned a number of things that I think as a community we're very much aligned with William and Mohammed talked about the USAID and Global Fund support over the years to really try to scale some of the interventions, and how the Global Fund funding has moved from 3% to 15%. From TB Reach, we're quite excited to have been able to collaborate with both USAID and Global Fund in a number of different countries to jointly support work and bring those interventions to scale. Places like Pakistan, Bangladesh, Tanzania, Vietnam have all been able to benefit from funding from the TB Reach as well as USAID and Global Fund. We use, and to your point, Monica, we use an open call for proposals to source ideas. We have an independent review committee that looks at those proposals and makes funding recommendations to our board. And our funding model really encourages this kind of different ideas and thinking about how best to engage a hugely varied and vast private sector, and tries to get those ideas to come from local implementers specifically. We have all seen the amazing work that has been going on in India specifically, and that a number of years ago the Gates Foundation provided early funding for, and Global Fund has taken up. Other initiatives also starting in India like IPAC, and we now see a number of TB Reach proposals and grantees looking to take some of those ideas and test them, adapt them to their own countries to see how they work. This year alone, in 2020, I think we presented at our board just last week all of the work that is being done, and while COVID has certainly had a major impact in a number of places, I think we really were able to move full steam ahead virtually. We launched and executed a call for proposals, really thanks to additional funding that came in from USAID, and that was augmented by some Canadian support. So we added 13 new grants this year in Wave 8 for almost $6 million in 11 countries. Those projects are just getting started now. And as always, there are a great mix of interventions and approaches from projects across Africa, Asia, and Eastern Europe. Now, the COVID-19 pandemic has certainly caused a number of our grantees great havoc, and has stalled or really just stopped activities in some places. But as Madhu, Lal, Mohammed have all mentioned, there have been a number of places where our grantees have been able to lead the COVID response, whether that is through the outreach efforts that they're doing, but also these a lot of the new tools around telemedicine, digital health. In Wave 6 through Gates Foundation support, we piloted a number of digital adherence technology solutions that have been taken up immediately, incredibly fast by many countries now through Global Fund funding requests. And this is public as well as private sector, but certainly these kinds of interventions are gaining a lot of interest. And so, overall, I just to say that in the last 3 waves, Wave 8 was dedicated to private sector interventions. But over the last 3 rounds of funding, we've been really able to increase the number of projects and grants involving the private sector because of the support that USAID has been putting into TB Reach, which has allowed us to leverage the existing Canadian funding and increase the number of projects that's supported. We are currently in the midst of a replenishment campaign. And as I said, we had a board meeting last week. The work that has been done by many of you who are on this call was incredibly well received. We had really great support for the work that the TB Reach is doing, and we're hoping that that support by the board turns into continued support by our donors. And I hope that we will have additional calls for proposals in 2021, maybe specifically on PPM issues, and also be able to provide some results of the Wave 8 funding in the not too distant future as well. So thank you, Monica.
Thank you very much, Jacob and colleagues, for your excellent interventions and for setting the scene. Now I would like to give floor to my colleague Monica Diaz, who is leading work in the Global TB program on public-private mix she's involved already for 13 years in this work, and she is also cross-cutting lead for the special initiatives like Director General Special Initiative Find Treat All and TB Elimination. She will present a global overview of the progress towards our targets, with a specific focus on the engagement of all care providers into this progress and response. Then I would suggest also to share the meeting objectives and agenda. Please, Monica, floor is yours.
Thanks so much, Teresa, and hi everyone again. So very quickly, I have a few slides to share with you the global overview that's been presented in our global tuberculosis report. We have new data which came out last month, which comes from all the countries. There has been significant progress made in 2019, and I will share a few perspectives of what has happened over the past year, especially, and looking ahead. So here again is a very quick again, to remind you about the gap. More people have been reached with quality care than ever before. We have 7.1 million people reached, yet the gap remains 2.9 million who still are not, who are undiagnosed or not reported. And we know that a big proportion of this gap are people who access care in the public non-NTP sector or in the private sector. Here is a very quick overview of public-private mix contribution to case notification. So before I go into this, I'd like to flag that as we look at closing the gap, PPM plays a big role, but PPM is not just about private sector engagement, because that's the vision people have. And you will hear in later sessions, especially from countries like Indonesia, like Ethiopia and others, about the role that big hospitals play or other public non-NTP sector providers. So we have public-private mix comprises of two things. One is public-public mix, which refers to engagement of a country's national program with public health sector providers of TB care that are not under the direct purview of the national TB program. This includes, as I said, public hospitals, medical colleges, prisons, detention centers, army, military facilities, public health insurance organizations. We have, for instance, colleagues who are joining us from the Latin American region of PAHO, where you have these social security organizations. So this could be an example. And public-private mix refers to engagement by the National TB program with the private sector care providers. And here you have private for-profit and private not-for-profit. So later on today, you will hear Guy Stallworthy from the Gates Foundation speak, do a deep dive into private for-profit engagement. So in terms of nonprofit includes faith-based organizations. We also have the corporate or the business sector. So coming back to this slide here about the contribution of PPM overall to TB case notifications, as Teresa and others have alluded to, we have the big 7 PPM priority countries that have 60% of the missing millions. And in these 7 countries, you can see the progress. And looking back at, looking back a little bit at history, in 2010, I was at the meeting. We had a PPM working group meeting just like this. And I still remember we had Dr. Mukund Plekar, who was leading the work at that time on PPM. We had Knut Lundroth, who is now in Sweden. And of course, myself as a young person joining WHO. And the focus really was that data is not being reported at all. So how do we get this data about PPM contributions? And that's where it began. So you will see that for many of these countries in 2010, there was no data being reported at all. And this has now transformed. And in the big 7 countries, you can see that the PPM notifications have increased from 225,000 cases or people ill with TB overall in 2010 to more than 1.8 million people with TB notified in 2019. So this is a massive increase. The proportion of total notifications contributed by PPM in these countries increased from nearly 10% to 30% in the same period. For public mix, the increase was from 6% to 12%. So you can see the massive progress that we've made. And here is a very quick snapshot, as I said, of public mix. In addition to the big 7, where you could see the increases for public mix, I'd like to flag China, Iran, Thailand, Vietnam. And here again, you see that, notifications or the contribution of public mix has been significant. And looking at public-private mix, there are other countries beyond the big 7 where you can see increases from Afghanistan to Swaziland, Ethiopia, Ghana, Kenya, Malawi, Nepal, and Thailand. And the reason I want to show this slide is also that, very often private sector engagement or public-private collaboration is often seen as something that's very Asian, not really, that affects other regions. But here you can see many countries from the African region featured, and this is where we see a huge gap where private sector engagement can really be scaled up. So moving on, a lot of the progress that we've seen, and you've heard some of this from the partners and the stakeholders who spoke already about, what has contributed to this increase in notifications. And we've seen this from the WHO NTB strategy in 2015. We had the first ministerial conference in 2017 and the UN high-level meeting. All of these high-level meetings and have resulted in commitments that have led to this massive increase in reaching all people with TB care. And this has seen a spike in notifications. Also contributing to this is the Find Treat All NTB initiative, as well as the Global Fund strategic initiative. So all of this has really driven progress. And this has been presented in the UN Secretary General Progress Report on TB. It's brilliant that for the first time we have, a UN Secretary General Progress Report on TB, which has never been seen before, where we have such a high-level spotlight. This has been developed with WHO support, and it highlights what the progress has been over the past 2 years. And a little beyond from 2015, and it highlights recommendations moving forward. So in terms of progress, so we have this target of 40 million, and you can see here that we've reached 14.1 million people with care. These are the people who were treated between 2018 and 2019. And if you dive deeper into it, you will see that a big contribution has been through PPM. Likewise, there are targets for children, drug-resistant TB, both for all ages as well as in children with drug-resistant TB. And it's good to put a spotlight on drug-resistant TB, and I'll come to that in a bit. And also to highlight that, again, children, it's the same issue where most of them, the first point of care will be pediatricians who are often in the private sector and not in the public sector. So there's been progress there. However, challenges remain. One is drug-resistant TB, which remains a public health crisis. So here you have about 500,000 people with drug-resistant TB who fell ill with drug-resistant TB. Only 38% access treatment. So there's a massive gap. And this is World Antimicrobial Awareness Week. And it's good to put a spotlight on this issue because PPM can help address this two ways. One way, of course, is to prevent mismanagement and the creation of drug resistance. And the other is to really help close gaps in care to ensure that all access care, all have access to quality care. And then the other issue is TB preventive treatment, where we're really lagging behind overall. But I think this is one area where we haven't in PPM really stepped into. And again, this is one area where you can see that we're only 21% of the way to reach the target. And we can make a big difference here if the PPM working group and all of us combine forces to help scale up TB preventive treatment. Next, I'd just like to flag the COVID-19 pandemic, which threatens to reverse gains, as many of you shared. We at the Global TB Program have been collating a lot of data from over 200 countries, and we've seen sharp drops in notifications, which obviously impact on lives and suffering. And we have a modeling analysis that's done both by us as well as the partnership, which shows that there could be an additional 400,000 deaths in 2020 alone due to drops in notifications. So we really need to get all hands on deck to combat this. Here is a very quick look at drops in notifications across the globe. Looking at TB cases notified from January to June in 2020. And again, if you look deeper, for instance, if you look at India, and this is data from our global report. Sorry, the slide didn't come. Right, and here you can see that, very clearly the private sector drop has been significant as well. So what will happen if we unpack other countries as well? And this has been happening you can see this in Philippines, in Pakistan, and tomorrow both Madhu and Nim will discuss this in more detail. So getting on track to reach targets with the COVID crisis, we have 10 priority recommendations outlined in the UN Secretary General's Progress Report. And here you can have a very quick look at it. It's from high-level leadership, funding, UHC, drug-resistant TB, preventive treatment, to human rights, stigma and discrimination. As Funke shared, this is an issue. Getting civil society communities and affected people involved. This is important. Investments in TB research, and of course, combating COVID. And of course, there's a request to WHO to prepare for the next high-level meeting in 2023 and take forward all of this work. So I'd like to spotlight one recommendation, which is number 3. And here we have a very clear recommendation to scale up and leverage the capacity of private and other unlinked public healthcare providers. This clearly provides the impetus for pushing forward on the roadmap that we launched in 2018. So this is a great opportunity, and we will be called into account, as this is a recommendation by the UN Secretary General himself. So this is something, as a PPM working group and as partners working together, we need to take forward. So that's a very quick overview. I'll now come quickly to the objectives of this meeting, given the lack of time. So as you can see, our objectives are threefold. One is to review global, regional, national progress. We discuss the progress in rolling out the PPM roadmap, reaching the target, what can we do together as a community, and deliberate on the impact of the COVID-19 pandemic on the TB response, specifically on scaling up private sector engagement. The meeting is spread out over 2 days. Today, the 23rd of November, and day after tomorrow on 25th of November. Here is a quick overview. Later today, we will have a session on progress and challenges in scaling up private sector engagement with a deep dive from Guy, with a special virtual roundtable with countries led by William. We'll have the PPM Learning Network, which will be presented by Petra. We have colleagues from Vietnam who will present on drug-resistant TB, and we will do a pre-launch of the landscape document. So you will see all of that. And on the 25th, the focus will really be on COVID-19 and PPM, and this will be led by Madhu, with Madhu, who will basically do a scene setter, along with Nim Pati from Imperial College, who's done a bit of modeling work, which will be interesting to see. There's a very interesting panel discussion with private practitioners on challenges and solutions. And we plan to have a big talk, which is a bit of a surprise, with an award-winning journalist, and followed by breakout groups on how we can build back stronger, and ending with an overview of next steps. So the format of the meeting is going to be very interactive. It's being streamed live on the WHO NTB forum. And my colleague here will put the link to the forum on the chat. So please do log in so you can, watch using the live stream, as well as you can see the live feed where you can provide comments, questions. We invite you to also, post your questions on the Q&A function and the chat. We have space for discussion. So we really want to hear from you and to interact with you. So that in a nutshell is a very quick overview. Thanks so much.
Thank you very much, Monica. It was a very nice overview. Now, turning to you again.
Okay, so thanks so much, Teresa. So now we have with us our colleague from the Universal Health Coverage Department, Dr. David Clark. So over the past couple of years, he's been really leading the work on UHC and private sector engagement, and especially over the past year, there has been excellent progress at looking at the COVID-19 crisis and private sector engagement. So we're very happy to have you with us here, David. Look forward to your presentation on the roadmap and your plans ahead.
Oops. Thanks, Monica. I've got some slides. Can I just share the screen?
Yes, please do so. There, I can see you.
Excellent, thank you. Thanks for the lovely introduction. So I'm David Clark. I work in the UHC cluster, as Monica said. I'm the focal point for the work on private sector engagement. We've been working on this topic for a couple of years now, so we're a long way behind our TB colleagues who have been working on this topic for a lot longer than we have. But we are definitely learning from the experiences of our TB colleagues. And what we're trying to do with our work is to focus very much on the governance issues associated with private sector engagement. And we've discovered as part of our work that there are many weaknesses in member states' abilities to work with the private sector, which really are governance problems. So in 2019, we decided that we needed to get a good handle on what we should be doing to prioritize our work in this space. So we set up an advisory group of experts to help us with this work. And right in the middle, you can see Madhu. And the reason that we wanted Madhu to be part of our panel is we really were conscious of the great work that had been done in the TV space. And we really wanted to learn from it in relation to the work that we were going to do in a more cross-cutting way. So
sorry, David. Sorry to interrupt. We can't see your slides.
Oh, you can. Sorry. Oh, sorry. I'll try again.
So it's share screen.
I'm very sorry about that.
They look like wonderful slides. They sound like wonderful slides, rather. Wonderful. If you could go on share screen mode, that would be great.
I'm just in the wrong place, I think. Whoops. And so Zoom is not my friend.
If you could click slideshow, I think we're good because we can see your slides now.
You can? Okay, great. Slideshow from the beginning. I'll start again. Can you see the slides now?
Yes, perfect. We're on the strategy report slide now.
So this is to recap. So Madhu has been part of this process. We've learned a lot from the work of your colleagues in the TB area. And what we're doing is very much focusing on how we can bring this perspective of the importance of working with the private sector effectively into a horizontal framing. So not just looking at it from a vertical perspective in relation to TB and other colleagues who are working on the private sector engagement topic as part of their work, but very much looking at it from a horizontal perspective, from a governance lens. And our vision for this work is that we need a health system in which public and private actors collectively deliver on the realization of universal health coverage. And this is critically important for us, given the high percentage of private sector provision across all of our member states, and particularly member states in Africa, in Southeast Asia, and in India, and another big TB high burden countries. And what we're trying to do with our work is to try and build consensus around the means and strategies of engaging the private sector, but at this stage focusing on health service delivery. So we've just finished our strategy. The advisory group worked on the strategy for about 1.5 years. We paused working on the strategy for a little while because of the COVID-19 situation. I'll talk about that a little bit in a minute. But on the advice of the advisory group, we have finished the strategy. So it's been finished. It's been approved by WHO management, and we're just in the process of getting it ready for publication. But the core idea in the strategy is that for countries to be able to work effectively with the private sector, they have to be able to effectively perform 6 governance behaviors. And they are in the blue puzzle pieces on this slide. So the first one is about building understanding, which is very much about understanding the private sector, how it relates to the public sector, and how its work is contributing positively and negatively towards health system goals. The next blue puzzle piece is about fostering relations. And it's about all of the activities that need to happen in the health system to create the sustainable relationship between public and private. The third is about enabling stakeholders, and is closely related to the fourth, which is aligned structures. And these two are really about making sure that the stakeholders in the system have the tools that they need to be able to effectively engage between public and private. So it's not just the public sector having tools, it's also the private sector as well. And also in terms of the structural issues, we need to make sure that the structures and the organizations and the funding and health systems is well aligned with government's intentions to bring the private sector into its plans for efforts towards universal health coverage. And the fourth and fifth slide, the fifth and sixth slide. The fifth is about this long discussed and debated concept of trust. So we're looking here at how we can generate more trust between public and private, and also more accountability for the private sector and its behavior in health systems. And here we're very much looking at the moment at the use of data and shared metrics, so both the public and the private sector can better understand each other. And then the last one is we very much believe that most countries should have some kind of strategy or strategic approach for working with the private sector. Some countries do have a deliberative approach for the private sector, working with the private sector, but most don't. And we think that it's very important that the countries do turn their minds to how they would like to work with the private sector as part of their efforts towards universal health coverage, and record that in some kind of strategy, and then operationalize that through a range of different tools that they have available to them. Now, when we started working on the strategy, we didn't anticipate the COVID-19 situation. And in February, when COVID hit, we actually stopped working on the strategy, and we pivoted towards working directly with member states to help them with their private sector engagement efforts as part of the COVID-19 situation. And what we found when we did that was that many of the issues that we were discussing in the strategy were being played out in relation to COVID-19. So the weaknesses in governance that we identified and the need to be able to perform these governance behaviors very much was played out in terms of the COVID-19 situation. So that's why we pivoted back to finishing off the strategy. And now our work on to support member states as part of their response to COVID and the private sector engagement is proceeding in parallel with our work on the strategy. Because we think that although the strategy presented many challenges and presented many weaknesses in health systems, it also has generated a lot of opportunities. We think with all this discussion of a new way of doing things post-COVID, a COVID reset, that it really does present an opportunity to find a new social contract between the public and private sectors in relation to the delivery of all sorts of health services, and particularly efforts towards universal health coverage. So in the COVID situation, we did a lot of work. We spent a lot of time trying to identify the key issues that member states were struggling with, working with the private health sector. And the probably comes as no surprise to many people on this call, because there are many of the issues that the TB community have been struggling with as well. We've also produced a lot of guidance to support member states and country offices to try and work on this topic. And we've been collecting and analysing information to help us to inform current and future private sector service delivery governance efforts. And we've been trying the best we can to get out these messages and this guidance to as many audiences as we can. And on this slide, you'll see an example of some of the things that we produced. We've been doing a lot of work more recently on producing a new guide on how to contract in resource-constrained environments. We've also got a new guide coming out on how to conduct public-private dialogues, all of which are really important tools for private sector engagement and critical things that our member states said that they needed our help with. I should just say that all of this material is on the Governance Collaborative website, and I can provide links to all of this different material for people. In fact, I sent this material through to one of Maddie's colleagues last week. The other thing that's happening at our end is, as part of the ACTA A Accelerator, the initiative that's run by the Global Fund, the World Bank, WHO, for distributing the COVID vaccine and other essential treatments for COVID-19. There is a private sector component to that. There's a health system accelerator that's part of this initiative. And as part of that work, we're looking at what we can do to support member states' efforts with the private sector. And we're doing that very much in partnership with the World Bank. So going forward, we think there are 4 main priorities which have been put to us by our advisory group about what we need to be doing next. And we're actually having an advisory group meeting tomorrow to talk about this and to talk about how we can operationalize the strategy. And the first thing that we wanted to focus on is this idea of convening political will. We hear a lot from member states and from different partners that there are still countries who are not fully engaged with this topic of private sector engagement. And therefore, we think that we need to do at WHO, one of the key things that we can do is to work with partners to try and build better political will for strengthening the governance of private sector and mixed health systems. So this is very much one of our key priorities, and we're just trying to work out how we best do that at the moment. One thing that's under discussion is maybe setting up a global forum for different actors who are interested in this topic, so we can work collaboratively with different development agencies and development partners to try and build the important political will in this area. The second thing that we want to do is to embed this work that we're doing on the governance behaviors into programming. So we're talking to various implementers like USA and the Global Fund and Gates Foundation and others about how we can embed these governance behaviors in their work. And we're very keen to try and create a cadre of private sector engagement specialists at country and regional level that can help us with these governance behaviors. And we think that these behaviours are very critical for the work of all of these partners, because really we think that these governance behaviours are something that is critical for a lot of different programmatic activities in relation to private sector engagement. The next area that we're going to do some work on in the next year or so is to support the setting norms and accountability for this very important area. And this is obviously a key WHO role. So we think that we need to set global norms and rules and policy around the governance of mixed health systems. There isn't very much at the moment. And we plan to set global indicators to support the monitoring of progress to assure accountability. And then the last thing that we really think we need to do more work on, and this is not just for partners, for member states and for people outside WHO, but also for WHO staff in the countries and regions, we need to do a lot more to support learning and technical guidance in this area. Obviously, some really great work has been done by a number of different partners, but we think there's more work to be done. And we've been told, and in terms of our research efforts, we've found that although there's a lot of really good material that describes the problems in relation to private sector engagement, there isn't very much around the how to do it. And so we want to do a lot more work to build the sorts of tools and policies and technical assistance packages that countries will need to develop and support their governance capacity and governance behaviours. And this will involve not just, as I said, people outside WHO, but WHO staff themselves, because I think it's fair to say that many WHO staff are not necessarily well versed in this very important area. So that's the end of the presentation. I was very conscious that I didn't have very much time today, and I'm very happy to share all of the information that we have about the strategy. The strategy is on the WHO website. There's a number of other documents I can also share, including a compendium of studies that we did to help us to prepare for the strategy, which has got some really useful information, I think, not just in relation to universal health coverage, but in relation to other efforts towards private sector engagement. So thanks for the opportunity to present to the audience, and I'm happy to answer any questions, or so back to Monica.
Thanks so much, Dave. There's, just to share with everyone, there's been such a major transformation at WHO for UHC with private sector engagement, thanks to Dave's leadership. Already in this past year, we've seen so much, as you can see with what Dave presented, and we're very happy that Madhu is part of the advisory group and has contributed to this as well. Thanks a lot, Dave. So now we're at the end of our opening session. It's been a lot of rich discussions. We are very happy to see that 200 people have joined, and we expect more to be joining or to be watching the live stream on the WHO forum. So now I turn to my colleague, my young colleague, Wong Yi, who works with me at the WHO Global TB Program, to lead us in an icebreaker. It's called a virtual PPM working group snapshot. So E, over to you.
Thank you, Monica. Hello, everyone. My name is Wang Yi. I've been working with Monica at the Global TB program. I'm really happy to join the PPM meeting. Actually, this is my third time to be one part of the PPM meeting since 2 years ago in The Hague. And last year, we had also successful meeting in Indonesia. As everybody knows, this year is being quite historical moment. I would like to show a small image here. As you can see, 2020 is a really historical moment, and everybody knows like all of our photos being framed. So as one part, we would love to record the 15th PPM meeting as one part of the history of 2020. So I really hope so now I request everyone to join me especially for the panelists, please see the chat. My colleague Anna will have to insert into the chat group. So through this link, you could able to download image, and then just a simple step, just to set it as your virtual background. So you will have a PPM meeting a virtual background, and then we will take a screenshot for all the panelists. And also, please open your camera so we can see all of you. Yes, for other attendees, as Monica just announced, we're so glad to have already over 200 participants to join the PPM meeting. But unfortunately, we're not able to see everyone through the camera. So I will send my email address in the chat as well. We also want you to be one part of our PPM meeting. So please send me your screenshot or your selfie, happy selfie with the symbolize of our PPM working group, and I will make a giant photo collage. And also everyone will be one part of the history of PPM meeting, and also the one part of the history of 2020. May I see everybody to set your background, and I would love to take please turn on your camera. I will take a screenshot now.
So we can see Nim has changed his background already.
Yes.
Monica, do we need to get out of Zoom to be able to upload the image? No?
No.
No,
Where
we
is the
don't.
setting for that?
Yeah, there is a simple step. First, we need to download the image to your desktop, the link that my colleague Anna just shared in the group. And then once you've got this image, only simply click a little arrow on the side of Start Video, the video sign. There is a little arrow, and then here is the option, Choose Virtual Background.
Is it the last link we can see on the computer?
It's, it says, PPM, a working group background. Can you share with all attendees, Anna?
All attendees.
Yes, please.
It's not working in my...
It's www.who.int.
PPM.
Yeah, I see Jacob now is.
We see first champions.
Okay, there's Madhu. As you can see, everyone's coming now with the PPM background. It looks really nice. And for those who can't, as E showed, you can open it up on your computer and then just take selfie. I think we're all proficient at this now. Wow, this looks nice visually.
Okay. So.
Okay. Lal, can you not manage? Lal, what's happening?
I clicked on that link. Then I see a kind of banner, global meeting of the working group.
Yeah, so you right click and save image as and put it in your computer. Save image as and save it on your computer, and then use that using the, yeah. Okay. Mohammed, are you okay for this? Dr. Lavansan, Funke, can you manage? Shamim, for some reason, it's making you glitter.
He's shining. He's our star.
I can take this screenshot and. So everybody now, I will say cheese, and I will take a screenshot for everyone here, and please give us your big smile. Okay. 1, 2, 3. Cheese.
PPM.
PPM.
PPM to NTB.
Okay, great. It's wonderful. Thank you. Thank you so much. Thank you, everyone.
So thanks so much. Yes, thanks. Thanks so much, E. So as you saw in E's presentation, let me show you again so that you can see. Let me just highlight this picture where you can see E and Anna, our two youngest PPM champions. So even a simple thing as that, put it on your phone or your laptop and take a selfie and send it to us. E is compiling the collage and her email is in the chat. So she's waiting for your email photos and she will make a giant collage that we will share with you on Wednesday. So thanks so much, E.
Thank you.
Okay, now coming back to our session. So now we move to the second session, which is being chaired by Dr. Teresa Kasaeva. So I hand it over to you now, Teresa.
Yes, thank you very much. It was very nice exercise. You've seen that new energy, young people are coming, bringing some interesting ideas to the PPM. And I think that hopefully we will not need another 15 years because we have no 15 years to NTB. This time period is much shorter. So we will succeed. No doubt we should succeed. No other choice. Now I'm pleased to chair another session, session 2, and this session will be focused on a very specific topic. So we will basically deep dive into PPM progress and challenges in the countries. So, and I would like to give floor first to our colleague and friend, Dr. Guy Stolworthy, who leads the work on private sector engagement on TB at the Bill and Melinda Gates Foundation, to present an overview of the recent trends in private provider engagement in the Big Seven. Guy, floor is yours.
Thank you very much, Dr. Kasaeva, and thank you, Monica, for sharing the slides. I hope they're visible.
Yes.
So I'm going to present some data and some thoughts on recent progress in engagement of the private for-profit providers. As Monica said, PPM is a broader issue than that, but involving public providers and non-profit providers. And I'm going to focus on the private for-profit sector. And we've seen a lot of very impressive progress in the last few years, but I also want to introduce a bit of caution at this point and frame the challenge that we're facing. So next slide, please, Monica. Monica referred to the 2018 PPM roadmap, in which the so-called Big Seven were highlighted. And this chart shows both the reasons for that focus on the Big Seven and some of the progress. It's not a very clean chart, but the horizontal axis shows the approximate percent of healthcare that is happening in the private for-profit sector in these countries. And the vertical axis is the numbers of missing TB patients. And what we see here is the countries in red, the Big Seven countries, are those with dominant private healthcare markets, over 70%. But also what we see is the considerable progress that people have referred to today in the reduction of the numbers of missing cases, in particular in some of these high burden countries with huge private sectors. Notably India, of course, and Indonesia, but also Philippines and elsewhere. So this has been huge progress in finding the missing millions in the last few years, and the contribution of the better engagement of the private for-profit sector in those countries where it's particularly relevant. Next slide, Monica, please. And in the big picture then, we've seen this incredible growth of private for-profit notifications, more than 1.1 million in 2019 for the first time, out of that 1.8 million that Monica referred to in terms of PPM in general. Now, 1.1 million across the big seven countries, representing last year 20% of estimated incidents in those countries. So this is indeed a very significant change, and Lal reminded us of how far we've come in the last 10 years on this topic. The next slide, Monica. As we see here, India, of course, has driven so much of this increase. It's such a big country, and so just in terms of the numbers, that's where much of this has happened. But most of the other countries have shown quite significant improvements in private provider notifications as well. Next slide, Monica. So now just continuing to focus on the data a little bit. Here we see the private, again, for-profit notifications as a percent of the total notifications in each of these countries. Philippines, India, and Pakistan rising to 30% now. Bangladesh was there in earlier years, slipping just a little bit, and similarly Myanmar. These are two countries that had made very strong early progress in private for-profit notifications. It's worth remembering that in Bangladesh, unlike the other countries, this data is referring to referrals from private for-profit providers who are subsequently managed by public and NGO services. But in the other countries, by and large, this refers to management by private for-profit providers. Next slide, Monica. In terms of population size, interestingly, Philippines is quite an outlier here, having high TB incidence, but in terms of population, they're all at a similar level per capita, except for Philippines having made huge progress in the last few years. Next slide, Monica. But in many ways, of course, what's most relevant is the relationship between these private notifications and TB incidents. And here we see, again, this huge progress in India, Indonesia, Philippines, and Pakistan over the last few years. Bangladesh maintaining pretty high contribution of referrals, and Myanmar and Nigeria maintaining fairly stable levels. So that's all good news. And a lot of people on this call, of course, have made significant contributions to either implementing these programs or funding them. I do want to just call attention to some of the recent increases in at least 3 of these countries that I think give us pause. And I've highlighted some of the question marks, if you like, on this slide. Monica, if you go to the next slide. The question we have to ask ourselves is whether these notifications are being accompanied by service provision. So starting with India, the blue chart line here is the private notifications, and the green line is the reported treatment success, which is lagging behind, but reported treatment success is increasing quite nicely. The other lines are showing that it's proving quite difficult to achieve high levels of coverage of program services, such as the program supplied drugs or diagnostics, appropriate diagnostics. In India, they have very, very impressive payment system to TB patients. But the private TB patients, only around 20% of those have been covered. Similarly, around 12% of the private providers have had the incentive payment due to them. So I think it was 27% of privately notified patients had had a home visit from program staff. So the real struggle is now no longer finding these TB patients. They've been found. They were hiding in plain sight, actually. They were there in the community. And many of them are being found now. There's still many more, of course, to be found. But the big challenge is not so much finding them now, it's extending program services so that they get quality care with financial protection. Turning to Philippines, the top right, no, previous slide, please, Monica. Similarly, important improvements in private TB notifications, but 90% of the increase in the last 2 years has come from the mandatory notification app in Philippines. And in this case, this is an important, as many countries are doing, they're issuing mandatory notification legislations and decrees and launching apps to facilitate the notification. But it's very hard to get anything other than information that here's a TB patient. It's hard to get any information about the outcomes or the regimens or the diagnosis that these patients have had. In Indonesia, there's also an app, but it's called Wi-Fi TB, which has similar challenges of getting information about the outcomes, but it's a much smaller scale. What's happened in Indonesia has been this famous mopping up exercise. And what I'm showing here is that a big part of the increase in private notifications in 2018, especially, less so 2019, was from the mopping up, the finding previously treated patients in the records of private facilities and getting that information in the registries. So we see a challenge of extending new quality assured services to these patients that we're finding. Next slide, please, Monica. And so finally, I think maybe we should remember that it's not enough just to find these missing, so-called missing TB patients who've actually been there all along in the community, walking around. We have to figure out how to extend program services to them. That impressive increase to more than 1 million notifications. We have to ask ourselves, do we have 500,000 unserved notified patients? And so maybe we need to think about the missing, rather than the missing TB patients, we have to think about the unserved TB patients and tackle the really difficult challenges of extending quality services and financial protection to them. We do know how to do this. It's been done. It's being done increasingly in every country, and certainly Pakistan and Myanmar, Philippines, every country has good examples about how to do this. But this is just a call to focus on the extension of program services and not just the notifications. Monica, back to you.
Thank you very much, Guy, for the excellent presentation, and it's very important. It shows very important trends and gives analysis and opportunity to think further. What are the real issues now? Of course, we cannot be satisfied only by finding. We should definitely go beyond and provide services. And furthermore, we should not think about only diagnosis and treatment. We should think about preventive treatment. It's another task, and all these activities should go hand to hand. So thank you very much once again. Now I would like to move to another set of speakers. We have now a special roundtable that will be moderated by Dr. William Wells from USAID, with an excellent lineup of speakers from countries and partners. Over to you, William.
Thank you very much. Thank you very much, Teresa. So, Monica, we start with the video. Is that correct?
Yes.
Thanks. Good morning, good afternoon, and good evening to all the participants in the PPM Working Group Special Virtual Country Roundtable. Our topic for this session is PPM progress, insourcing versus outsourcing, how to make the choice to scale up private sector engagement. We're lucky to have a very impressive group of participants from national TB programs and implementing partners. But first, a bit of context. Around 20 years ago, our colleague Mukund Uplika set out the private provider engagement challenge for all of us. To put it simply, national TB programs have limited staff, but need to engage with a large, complex, and relatively unorganized group of private providers. This need to engage gave rise to the idea of the intermediary as a foundational concept for PPM. The intermediary would be an entity that would reach out to the large number of private providers and aggregate their efforts into a form that could be managed indirectly by the National TB Program. Donor funding of intermediaries has generally followed this kind of outsourcing model, meaning that the implementing task is contracted to an entity such as an NGO, even while the overall steering of this effort remains with the government or the National TB Program. But these donor-funded efforts have been temporary and incomplete. The question now is, how do we reach a sustained national scale via an increased effort with both donor and, very importantly, domestic funding? Should this national scaled-up effort be pursued by the outsourcing approach, in which the government contracts with implementing organizations to get outcomes that serve the overall NTP goals? If yes, what are the government and implementer capacities that are needed to make such a system work? Or are certain governments able to overcome the early difficulties seen in the very first PPM efforts and do their own private provider engagement? This would be a form of insourcing or doing the work themselves with their own staff. If yes, then where will that staffing and those engagement skills come from in order to make the insourcing feasible? Over all of this hangs the biggest question of all: how should governments decide between these very distinct outsourcing versus insourcing approaches as they chart a clear way forward for private provider engagement in TB in their country? These are the overarching questions that we will consider today. With that as background, I'm delighted to start this session with a question to Dr. Lowenson from the National TB Program in Nigeria. Dr. Lowenson, recent efforts with state governments, such as in Lagos and Kano states, supported by Shops Plus Nigeria, have highlighted that private providers can contribute up to a quarter of all TB notifications in a state in Nigeria. This has followed an outsourcing model in which local organizations are primarily responsible for implementation, but guided by the NTP. These efforts had a catchment population of almost 45 million people in total, but now the challenge is how to sustain and even scale these efforts further, either with donor or domestic financing. What do you see as the next step in this effort now that we know that success is possible?
Thank you very much for the question. And I want to start by, first of all, appreciating the support that we've had from our donor partners. We've done tremendous job for the USAID, for the private sector through the Global Fund as well. I want to, again, start from the point of you said outsourcing through the donor or domestic funding. Well, having appreciated our donors and using the resources through the outsourcing to local organization, we believe that with this we have been able to do have a lot of gains. However, this gain is early because it is what we learned from what the SHOS Plus did for us that made us we saw the successes that were recorded using that model. And that model helped us to be able to, again, use the resources from the Global Fund to also scale up services, apart from the 2 states that are supported through SHOS Plus, to an additional 20 states through the IHVN in country. And I would say that for us going forward, this outsourcing, we still want to maintain it as our next steps because we have seen that it has assisted us greatly. And then we believe that as we move along even with the resources from the donor, the international intermediary organization, we also, they will learn a lot of lessons. We will use this to build their capacity, strengthen them, to enhance their cost effectiveness. And what I mean by this is that they will have been able to have a lot of capacities themselves to be able to mobilize resources through domestic resources, maybe through social health insurance, as well as even donor support to be able to continue to provide the services as years goes by. We know that private sector is where a lot of our people, about 70% of our population, that is 200 million people, access services. In the spirit of universal healthcare coverage, there is still a lot to be done. And we still want to use this as sources to, again, saturate everywhere the private sector, particularly with the result that we are getting right now. We want to use this opportunity to be able to achieve more. Beyond the using the intermediary, getting resources from even the donor, we believe that in country we are making some effort as well. We are developing some roadmaps in the sense that we are looking at putting together the presidential task force on the initiative on ending TB. And we believe in this task force, we have big philanthropists, we have big private outfits, where we can leverage on their resources also as domestic resources to be able to support the private sector. I believe in doing all of this will help us a great deal to be able to use also some of our domestic resources. But more importantly, we still want to say that the donor resources is very, very crucial to assist us to be able to achieve universal healthcare coverage under the PPM for TB. So that's the few words that I have.
Fantastic context. So maybe just one follow-up question. I'm wondering if you can describe a little bit the role of the NTP specifically in this plan going forwards. What are the actual steps?
Recently, what we do as a national level is to coordinate all these efforts with the partners, just all that is going on in country. And then as a next steps, as I said earlier, we still want to maintain this our outsourcing through the donor support that you are giving us. In fact, we need more because of the universal healthcare coverage. We will still maintain our position of steering, coordinating all of these efforts together. And through this, I believe we will have built the capacities for us to be able to see how best we can do this ourselves in country using domestic resources in future. So for NTP, we still want to maintain our current level of coordination and steering all the supports and all the operations that are going on in the PPM arena in country for TB.
Great, thank you so much. Very, very helpful. And it sounds very promising. So I turn now to Bola, who has been working with SHOPS Plus on this effort. So from an implementer perspective, Bola, where do you see the future opportunities, specifically in 2 areas, the ability of local organizations to implement and the capacity and willingness of government to promote and guide this kind of outsourced work? in the future?
All right. Thank you for your question, William, and hello, everyone. The PPM model implemented by Shops Plus in Nigeria has been a proof of concept. The concept that outsourcing works, that is, it is possible to significantly increase TB case finding from the private sector when the government engages with an intermediary like Apt Associates in Nigeria implementing Shops Plus. The Shops Plus TB program is being implemented in Lagos and Kano, and right now in 16 other states, but we started off from Lagos and Kano just to show and that it works to start with. And what we found was that we're able to increase the TB case notification from the private sector from 3% to 21% in 2 years in Kano, and from 12% to 22% within the same period in Lagos. And looking at the successes we have recorded in these two states, the same concept of using intermediaries to outsource was scaled up to 20 additional states using Global Fund resources. And then we covered the entire country using USAID resources to scale up to the 16 other states remaining in Nigeria, including the Federal Capital Territory. And one of the first steps we took was to bring together the private sector players using their umbrella associations, national doctor associations, the lab associations, the community pharmacists, and the patent medicine vendors, the drug shops. And we had a consensus building meeting where the government was present, and these organizations, private health organizations were also present, and of course, Shops Plus, comprising of the Apt Associates and the local intermediary organizations. And from that moment onwards, the distrust between the government and the private sector started to weaken. And over the years, we've seen a lot of collaboration, a lot of handshake across both parties, working through outsourcing and through intermediaries.
So a couple of follow-up questions. One is around local organization capacity. So as you look at scale up, then you need to spread these kind of abilities to more and more local organizations. Can you talk a bit about how that process has been approached in Nigeria and any issues that have come up and any solutions to those issues?
All right, thank you. So for each of the states where we started off from, that is Lagos and Kano, interestingly, we got 2 local organizations with different capacities. So in Lagos, for example, we have Loving Gaze, who have been a faith-based traditional TB service providers. They've had a dot center for a very long time. They even had a GeneSpark machine, but they did not have a lot of programming experience. They did not have a lot of the ability to strengthen other providers because they have been a traditional DOTS provider on their own. So the challenge we faced was to be able to convert their skills in terms of TB service delivery to being able to build other people's capacity. So we had to focus a lot on improving their programming skills, their mentoring skills, and their ability to provide step-down trainings and capacity building to private providers. Now in Kano, interestingly, the reverse was the case. So we have Society for Family Health, who don't have a lot of TB program or TB service delivery experience, but have a lot of program experience. So we have to build capacity and strengthen them to understand the TB program and provide direct support to providers providing TB services. And what we've seen is a gradual increase and improvement in their skills in both ways. So we have Loving Gaze now being strengthened to be able to mentor, to build capacity, to provide reports, and to improve their programming, generally speaking, and to support private providers. Of course, a lot of oversights from Apt Associates and Shops Plus. Now in Kano, we also see SFH being able to also provide TB service delivery capacity building to providers as we also strengthen them and build their capacity in that regard.
Great. So you described it for Kano and Lagos. How has that then played out in terms of expanding to the 20 states?
So for Global Fund, in expanding to 20 more states in Nigeria, they replicated almost exactly the same model. And that's a success story for us as a country and for Shops Plus and USAID. because that model sort of formed the basis and like the framework for private sector engagement for TB in Nigeria going forward. So that model has been replicated or is being replicated in about 20 states with different degrees of successes, no doubt. Now, for the other 16 states that USAID expanded to, what we did was to replicate that same network formation activity. But now, directly, Apt Associate directly works with the state's government, and we have facilitators in those states who also engage staff similar to the network officers we have under the intermediary organizations, such that the governments in those states, in those 16 states, are still in the driver's seats, but then they have foot soldiers in form of the staff from the Apt Associates who are like ad hoc staff supporting the private providers and reporting directly to the TBL supervisors who are the government agents at the local government level. So it's the same model, just in a lighter touch. Fashioned after the PPM Light model in India, where in some states we have direct implementation through an international organization and the government working directly with the private providers.
Great, thank you. So it's a very interesting model. In a sense, you're almost describing for Apt Associates a role as an intermediary of the intermediaries. So there are intermediaries below you, but Apt Associates itself is almost acting as a guide for those other organizations. How do you see that role, that guiding role, evolving in the future? How can it become a domestically based function?
We've seen their capacity evolve and improve over the years. And what we are looking at is getting them to the point where they're able to source for funding locally. And because it's maybe cheaper for them to implement working directly with the providers, maybe it is possible in the future to get some domestic funding so that it can be more sustainable. But our focus right now is to ensure that at least the entire country is covered, like we are doing, and there's saturation to a significant extent, so that we can make a case for more funding, be it international or domestic. By the time the successes are undeniable, you can make a compelling investment case for in government and even donors to invest more in TB private sector engagement in Nigeria.
Okay, so now we turn to Dr. Gaffin, the NTP manager from the Philippines. Dr. Gaffin, governance in the Philippines is very decentralized, which makes it challenging to implement a standard approach to private provider engagement, whether that be outsourcing or insourcing. In this context, is it possible to make a clear choice between these two general approaches for private provider engagement?
Thank you, William, for the question. So currently, it is difficult to standardize the approach because we are in a devolved health system and local governments have a choice as long as it follows government regulations. So however, insourcing is preferred by the local governments wherein they directly provide the health services and pay for its entirety. For private sector engagement, this could also include paying the provider directly for services rendered. Like, for example, if we engage them as a consultant or as a special service provider, but services are still delivered within the control of the government. Outsourcing is usually a less preferred option for several reasons. First, LGUs could perceive the cost of services will be higher if outsourced to the private sector. Or second, the LGUs do not have adequate budget to outsource. Or thirdly, the procurement process for outsourced services may be perceived as too tedious. Actually, if we review the current policies and guidelines, there is no specific provision for health service provision. the PPP or the public-private partnership that we have, the guidelines would show that it is more on e-health projects, infrastructure, and complex medical systems. And it does not cover provision of health services. Then another reason is that the perception that standards of private outsourced services may not be at par with the government program standards. So the way forward for us, since we're not really sure if it's outsourced or insourced, is the implementation of the Special Health Fund under the Universal Healthcare. In this system, the private sector will be part of the healthcare provider network. And the payer of the private service here is not necessarily the local government unit, but it will be from the established Special Health Fund, which is pooled funding from the national government, PhilHealth, and the local government. So this Special Health Fund will be managed by the healthcare provider network led by the local government unit, that is through the local health board. So the classification of services into either population-based or individual-based can help standardize the assignment of a payer for the service, that is PhilHealth for the individual-based, or the DOH or the local government unit for the population-based.
Great, thank you so much. That's fantastic context. I have a couple of follow-up questions, if I may. Firstly, for the special health funds, what would be the incentive for private providers to join those kind of networks?
I think one of the incentives is if they are part of the network, then they will have more access to the patients, since patients will be able to know who they are if they are part of the network.
And I'm imagining that the special health fund may be more for paying perhaps clinical services, but then you've still got the question of how to pay for the more kind of public health tasks. And so I'm wondering if you can talk a little bit about how you see that public health side being supported. So I'm thinking.
Actually, what we will be doing is we need to plan already that these services should be provided by the government. So there should be a transition period wherein the local government units should own the provision of the services.
Great. Okay, thank you so much. That's very, very helpful. So Pak Imran, welcome, and we're delighted to have you here. Could you give us an introduction to the current approach to private provider engagement in Indonesia?
Yeah, okay, so I will explain about this one. In this slide, it shows that it's important to engage both the public and private sectors because of the community preferences. Some people prefer to get diagnosed and treatment in public health care facilities, while the other prefer to be treated in private health care facilities. The condition shows that we could lose the opportunity to get notified TB cases if we don't engage public and private health care facilities. In addition to the notification loss, we also prone to lose control of the TB quality care. Here are the strategies that we developed for the implementation of PPM in 2020-2024. First is to increase involvement and strengthen networking mechanism between all health service facilities. Second, to improving the quality of TB service, including disseminate ISTC and other TB-related issues to all professional organizations. Third, strengthening the role of cross-program, cross-sector and community in the implementation of PPM. Fourth, to strengthen the implementation of mandatory TB notification by providing a reward and punishment system. The fifth, strengthening DPPM collaboration through health financing schemes. By piloting project of strategic health purchasing concept trial in several districts. Six, forming a hospital DB team, including conducting capacity building and mentoring. Seven, to support TB patient access from private services that related to the molecular rapid system, or we can say that we will increase the access to gene expert examination and an efficient specimen transportation system. And at last, we will build networks between private health services and community organizations for patient support, investigative contact, and TB as IV referral, and also promotional and preventive efforts.
Great, thank you so much. That's a very helpful introduction. So I'm particularly interested in the last strategy, number 8, this concept of keeping it all together, tying the pieces together, and the preventive aspects. How do you see that being implemented in terms of who will staff that function? How will it be paid for?
Yeah, so for the how to improve the involvement of COPY-TB, I think COPY-TB is was formed 2.5 years ago, and it's very, very young. So in the journey of how COPY-TB can benefit to the TB program, I think we need more support. Yeah. Most of them are what we call a specialist. Yeah. So the specialists, they don't want to get budget with the management things like reporting, recording, and so on. So we need a strong institution that can support them to manage this kind of the things like reporting, recording, and also how to what we call to assess the quality of care of the private provider. So I think if we can combine these 3 actors, and also we can add the BPJS, the health insurance, to be one of the system, I think the PPM will be much stronger than now. That's my perspective, William.
Great, thank you so much. So I'm again interested particularly in this idea of a supporting organization that you mentioned, since issues like recording and reporting are not tasks that the specialists want to take on. Do you see that specialist organization, would that be more likely to be a professional organization, an NGO, a CSO, some other?
I think for the kind of this organization to support the specialists or to support the professional organization, I think we need organization or CSO that have a strong what we call management, data, and also they have a capacity to make data analysis. Yeah. So we still looking for that one, because it's not easy to find in Indonesia, because this also still new. However, maybe in my perspective, I think if we can find the organization like local health insurance, yeah, or maybe like local banking, yeah, which they have the experience to manage the data, collecting data. I think it will be much easier for us to manage.
Great, thank you so much. Yeah, it's definitely, I think, a journey. It's unlikely that any organization will be perfect at this in the beginning, but it will take some learning. I guess my last question for you is about the financing of such organizations. Do you imagine that would be national financing? Would it be province, district? Where do you think that kind of organization that you just discussed, how would that be financed?
Yeah, I think since this is the approach is still young or is still a beginning for Indonesia to do the PPM, I think the financing should be from national level. Yeah. Because in national level, we can make or propose a budget to the president, yeah, to do the upscaling of PPM. Since you know that also our president have supportive to the TB program, and in 2021 we the president support us for the additional funding for the program is around 2.7 trillion rupiah. So it's threefold higher than 2020. So we will put some funding to the PPM. And thank God that the Indonesia got the global fund in the next funding in 2021 to 2023. And in this funding cycle, we also propose the PPM approach. So maybe it's like a hybrid. And in 2021 to 2023, Global Fund will cover the most of the funding of PPM. However, in 2022, we will start to fund the PPM approach by national fund. So that's my point, William.
Great. Oh, that sounds very, very promising. So I think exciting times ahead for Indonesia for this area of work. So thank you very much, Pak Imran.
Yeah.
So Dr. Sharman, India was an earlier adopter of PPM pilots, but those remain geographically limited. In more recent years, the country has taken dramatic steps to adopt widespread private provider engagement in TB, specifically through an outsourcing model in which donor and now government finances are used to contract local intermediaries. Can you explain how and why India arrived at outsourcing as the optimal solution for the Indian context?
So it all started initially when there was this big news in the Global TB Project, and everyone knew that there are missing million in India, and everyone kind of knew from the very beginning that it's all these were mostly from the private sector, which was much disorganized, less of regulatory control, and all kinds of things are happening. And to start it, and in the year 2012, there was this first humble beginning, which started off in 3 cities in Mumbai, Patna, and Mehsana, and which ultimately gave rise to this the Global Funded project, which essentially covered roughly around 50 cities in India today. It has been a long journey since 2012 till 2020. It seems that it was just yesterday, but it has been a long and tumultuous one, I would say. So if you So that has been the context on how it has been. It didn't arise overnight. It has now been kind of mainstreamed. There is domestic funding available. And in the current financial year, almost all the provincial governments have budgeted, and they are all looking forward to a larger part being played by intermediaries in this whole engagement of non-governmental players in engaging private sector. So this has been broadly the context on how it has been. But it had its share of challenges, I'd say, both for the National TB program and also for the implementers. And the reason was, like, when all these changes were happening, and they were happening pretty fast, and as I said, like, it was isolated in only 3 cities, which were giving results. For this transition to happen, we didn't have any clear guidelines on how this should be happening if you mainstream it. And with the results, what we saw in the global funded intervention, the Project JEET, now the government has also kind of, they have changed these guidelines, which earlier were more of an NGO engagement, to now what they're rightly being calling as the partnership guidelines. And it is all encompassing, and this intermediaries are a small part of it, though for private sector, huge private sector engagement, especially in the areas which are highly rural and environment, wherein you don't have really formal providers. It's mostly informal. So how do you engage with them? So these guidelines, it gives you that kind of flexibility. Like earlier, it was you used to identify an NGO and you give them an amount, and they do whatever they're supposed to do. And usually the contracting process was also was that the lowest bidder used to get it. So it drastically has changed now. So what the National TB program has been emphasizing more is that it should be more quality and cost-based selection, which kind of ensures that nobody undermines or undercuts anyone by virtue of bidding very low. So that is one of the biggest, I would say, intervention from the National TB program side. All other than this, what has happened is we had made a lot of collaterals for communication. As the project evolves, what kind of communication should be going in to the community, to the providers, or to the patients, and also engaging with the government. You know, like, it's not that when you start off what it should be like. So these are things which we have already shared with the National TB program and also with our partners.
Great. Thank you so much. That's fantastic. So it's very interesting, the CHAI role that you described in India. It's quite reminiscent of what Bola was describing for APT in Nigeria. What do you see the evolution of that particular oversight function?
So I think this oversight function will remain for some time. It's not necessary that it'll always be with, say, with CHAI or with, say, PATH or any other big NGO. This role has been increasingly being taken over by the National TB program. So recently they have through the World Bank, they're forming a technical support unit at the national level and also at the provincial level, which primarily would be doing this oversight work and helping how these contracts move on. I see it's a continuous process. It's not that today we end and tomorrow someone else would be starting.
Great. Thank you so much. So thank you very much for the perspective from India. And I think we'll now move on. So Atotaye, it's great to have you here. Thank you so much for joining. Could you give us a bit of an introduction to the context for private provider engagement in Ethiopia?
So this PPM model in our country, PPM model in our country are the first one is from the national program. In national program, they are directly involved in two ways. The first one is the main NTP structure, and second one is a PPM TB care provider. So this is the area of PPM engagement, especially in the past experience. So 257 health facility were involved in the TB diagnosis, treatment, and also referrals. The second part is 40 health facilities involved in providing with the TB diagnosis and the referral. This is a present experience. Currently, we reached around 885 private facilities are currently involved in the PPM. So currently, they were contribute towards the national TB case notification around 70%. So as a future, also addressing the gap in engaging all care providers. The first one is expanding the laboratory sample referral and the EPA network is included. Additionally, we plan to involve again 550 additional private facilities in a PPM TB site, as well as scale up of this feasible performance-based PPM model of engaging.
Great. Thank you so much, Taye. That's really very helpful introduction. So I have a couple of follow-up questions. One is about the general model that is being used. So some of the early work in PPM in Ethiopia was more project-based. USAID projects like PHSP had their own staff who helped with the engagement of providers. And now the model has shifted more towards the warrader or district staff actually taking up most or all of that work. Can you talk a bit about that change, and were there any difficulties with that? Were there any good practices in making that shift towards actually being the government staff who are doing this kind of engagement work?
Yes, as experience, previously it is NGO-based, but currently this thing is mostly shifted to the national TB program. As we were observed from previous presentation, mostly the NGO-based support is around 500 health facility was involved, but the national program is also involved with additional health facilities to providing the TB service at different health facility levels, especially the NGO-based, organization like PPM service is not sustainable. So as most of the NGOs phase out from the country, the program become collapsed. So to sustain this type of program, especially involving different NGOs like uniformed hospitals as well as private health facilities, the national program overtake these issues to sustain the program. So currently, the national program overtaking those NGO-based program to the national program and scale upping of the program. 3% of different private health facility involved in the TB case finding, but they are contributing around 70%, 70 to 20% to the national program. So,
great. It seems as though the job of engaging private providers, of reaching out to private providers, is more manageable in Ethiopia because there are not too many private facilities. Would you agree that this kind of structuring of the health system makes it easier to engage with the private providers?
Of course, it is the best choice for us currently. Ethiopia has opportunity. More than 10,000 of private health facilities are in the community, including in the rural community also, and different faith-based organization and NGO health facilities also in the community. So with a minimum support like training, supportive supervision, mentoring, the country will be benefited with available staff at the and infrastructure in the private health facilities. So this is the main opportunity for us, and currently also 20% of our patients first visit this private health facility. So this is the important area for TB case finding, and the area that we are focusing to working as a new strategic plan also for the next 5 years.
Thank you so much for your responses. Very, very interesting. Okay. Okay, great. So we're back live. We now have an opportunity to chat with almost all of the presenters live. And we have a number of excellent questions have come in. We won't have time to cover all of them, but we've asked Dr. Ocado from RIT to pose his question on quality, and perhaps to be directed to Bola and Shamim. Dr. Ocado.
Yeah, good evening or good morning, I don't know, so from Japan. So, okay, so my question goes to, I suppose, to everybody, all speakers, but because of the time, so constraint of time, so I think that's okay to 2 or 3 speakers may respond, or the others. So my question is, how do you make sure the quality of TB diagnosis, including laboratory services and treatment or care amongst the private sector while you expand the private sector engagement nationwide? So because if you expand such a private sector engagement nationwide, we have to take into account how to make sure the quality of care or quality of diagnosis of what they are performing. So specifically, what is the core of, we know that everything is very important, we know. So, but the question is, what is what do you think is really the core things, core mechanism or core component that we have to really make sure to ensure the quality? What do you think in your context, in the Philippines, India, in Nigeria, Ethiopia, or Indonesia? From your standpoint, what is the if you asked, what is really the core things? What do you choose? That is my question. I know it's a bit difficult to answer, but I'd like to know your opinion.
Thank you, Dr. Ocado.
Yes.
Bola, can we perhaps start with your response?
All right, thank you, William, and thank you for the question. So it's a 3-step process. The first is a formal training. So soon after the providers sign an MOU, after they are officially engaged and they have signified their interest and their readiness to work with us, we do a formal training. We train at least 1 person per facility. If we have more resources, we prefer training 2 people, a doctor and any other health worker from the facility. The next step is to do a step-down training in the facility, because health service provision is teamwork. So you're going to have other people. You have the pharmacists that are going to dispense drugs. You have laboratory scientists that will collect samples in those facilities. So what we do after the formal training is to have a step-down training within a month or so of formal training. We do a step-down training in the facilities where we have like a clinical meeting. We try to train almost everybody in the facility. And this is done by the intermediary organization. And that's another beauty of the outsourcing model. You have a lot of capacity in the field, a lot of resources to do step-down trainings in as many facilities as you train. The third step is to continuously mentor the facilities. You don't get it right within the formal training or even the step-down training for that matter. You have to keep going to the facilities. A lot of hand-holding has to happen.
you have to mentor and check what they're doing to ensure a high quality of care. So I'll call it a 3-step process, but the third one has to go on continuously. Thank you.
Yeah.
William? Great, thanks. Yeah, so thank you so much. Pak Imran, would you like to respond?
Yeah, thank you. So for me, I think the most important is how we can make attract the private provider to give or to provide the quality services. So in Indonesia, now we try to develop the branding for this one, so branding system. So it means that if the private providers can provide the quality services, they will be what we call the special, what we call the Minister of Health of District Health Office will bring them a symbol that provide this health provider provide the quality services, and it will be linked to the national health insurance. The incentive from health insurance is not the additional fund. It could be like the private providers could have the what we call the prioritize when they claim of the services, or they can have the special access to have another budget. So it means that we want to give the people to choose, or to give them the what we call the their perception of this private provider. It is good or bad health providers. So let the people participate to do the PPM work. It's not only government, not only private providers, but also the patient. Yeah. The people also have their involvement to this one. So that's what we try to do in Indonesia. Thank you, William.
Great, thanks, Pak Imran. It's a great reminder to keep the patient perspective and patient participation in this. I think this quality question is important, so I would like to also pose this question to Shamim about the perspective from India on how to maintain quality.
Thank you, Dr. Khara. That's a tough question to answer. From the current perspective, what we have been doing, I think the challenge is we are only engaging with the formal providers. When I say formal providers, it's the providers, those who have been practicing the modern allopathic system of medicine. So already we are filtering the providers whom we are engaging with. But I think the bigger question would be when we expand and we start engaging with the non-formal providers, those who carry, I would say, equal number of patients, those are seeking care from them. How do we standardize practice and start engaging with them? So that is something which we need to really look into. There have been examples from the neighboring countries, but then we really need to see how best can we develop a model in India and scale it up. Currently, what we have been doing here is, one, we engage only with the formal providers, we map the providers, those who are there. We have been engaging with the chemists and the diagnostic laboratories. So once we are mapping the diagnostic laboratories, it is only those laboratories which are following the diagnostic tools which are endorsed by the National TB program, primarily whatever has been endorsed by the World Health Organization. There have been it's been pretty interesting learning, I would say, as we have gone ahead. Initially, the providers, they were not really asking for bacteriological confirmation. When we started, it was roughly from say around 11% to now we have come to 40%. There has been some a good uptake of these good practices, I would say, and this has required more interacting, having continued medical education, continuous engagement within terms of collaterals. How do you show business to them? I think that is another big thing. Though we don't want to talk openly about business, but then this is what it matters when we start engaging with the private providers. So there are standard guidelines. It is more about how do you make it more acceptable to them. It's more on how you engage with them and put it across that, and primarily try to show them that it is not destroying the way they are functioning. There have been pretty good results. I would say that initially they were reluctant in prescribing these tests. They started prescribing. The turnaround time on these tests and the results when they come and the patients are being initiated on treatment has reduced tremendously. There has been a lot of uptake on the government provided fixed drug composition anti-TB drugs. These drugs are also available in the private sector. They have been using this from the very beginning, but then there has been some standardization and how they have been prescribing these drugs. This is one of the major challenges. What we see is the prescription habits. With the FDCs coming in, it has improved, but then we haven't been really able to scale it up. Roughly, it is around say 27 to 30%. That's what we see. Mostly still are going with the FDCs which is available in the market. As long as they are prescribing the right drugs, we don't see that it should be a challenge. As long as they are following the standard practice. Thank you.
Great, thank you, Shamim. This is very useful to see the problem being broken down into manageable parts. So, Dr. Godado, you had a question on digital use of digital technologies. Please go ahead.
Yeah, thank you very much, Williams, and all the colleagues for sharing those very nice experiences. Just permit me to ask two questions. One is on the ease of reporting from private sector has always been one of the key barriers for private sector engagement. And it would be nice to hear from colleagues if any of you have some experience in the use of digital technology to ease reporting from the private sector, because you are all aware that all private sector, all tertiary and academic institutions, military institution and paramilitary are always on the reporting TB because of the cumbersome nature of our reporting tools. So that is one. And second one, if you can share your experience with us on how to ensure sustainable reporting from the private sector, if reporting can be mainstream into accreditation and relicensing of the private sector practitioners, because they are all regulated by a certain bodies within our respective countries. So can we mainstream reporting into an accreditation and relicensing approach to ensure that it is sustainable rather than dealing with it only at a project level? Thanks.
Great, thank you, Godado. Dr. Celine, would you be able to start our responses to these questions?
Thank you, William. So for the Philippines, we introduced the ITIS Lite. This is the Integrated TB Information System. If you are part of the NTP network and you are in the public sector, then you use the ITs. But if you are in the private sector, we know that they are busy, so we devise a less toxic reporting for them. So we devised the ITIS Lite, so it has less variables. And this is now for both the Android and the iOS. So we have this system to facilitate the reporting of the private physicians. Then in terms of the reporting, the question is, can we include this in the regulatory system? For the Philippines, we have our mandatory notification wherein the physician should report their TB cases. So that's all. Thank you.
Great, thanks, Dr. Garfin. Dr. Lowenson, do you have some thoughts on this topic? I know there's been also work in Nigeria on use of digital tools.
Thank you very much for the question. Dr. Gidado is very much aware of what is happening in Nigeria. Regarding the reporting, because we have some of these intermediaries, they also assist us to get some of this reporting from the private sector. But beyond that, we have some digital tools that we are now started to deploy. We call it the MASS tool. Under the ShortSplot project, they have the TB Star, and they use that to report, particularly for notification. Then when you talk about mandatory, we try to do that in Nigeria to say, because we know, because of the low TB coverage, and because we are also now engaging with the private sector, we wanted them to ensure that they continue to report on TB. That is why we, at one of the, what we call National Council on Health, which is the highest policy-making body in health in Nigeria, there was a resolution that private sector will only have their license renewed when they report TB mandatorily. Well, even if it's zero report, if they are not, they must report on it. And that will give us the evidence that they are actually looking out for TB in their facility. Though we've started, some, like places like Lagos State is trying to make sure that they do that, but many of the other states is been a little bit of difficulty. They are doing that with difficulty, and we are not having the desired effect or the result that we anticipated at the time we put up that memo, and then it was agreed on as a resolution by the highest policy-making body in Nigeria. Thank you.
Thank you. That's an interesting development. Thank you so much, Dr. Lowenson. I'll just give a last word to Pak Imran. I believe there's some discussions happening in Indonesia about this last aspect of tying these kind of requirements to access to health insurance, for example. Can you talk a little bit about that, about making this process more mainstreamed in the regulatory process?
Yeah. So last month, our Minister of Health declared the special letter to have a mandatory notification for all health providers to report on the TB program. And this is the our minister mentioned that the special fund will be linked to the report of TB program from each health providers, especially from the hospital. So every year, Ministry of Health provide the special fund for hospital, especially for the public hospital. And next year, the assessment of this special fund will be linked for this. Will be linked to the regularly, how regular the hospital report the TB program. And nowadays we also have a discussion with the National Health Insurance to keep the health insurance provide the fund to TB program, because nowadays the coverage of health insurance is so wide, and we want to have like focusing on what kind of the support from national health insurance about the program. So in Indonesia, we have discussed to have mainstreaming, like William mentioned, on several programs. So we will focus on MCH, TB, and HIV. So why only 3? Because these 3 diseases or 3 health problems is linked to the minimum service standard for every district. So it means that we will be, it should be mainstreaming for these 3 programs. And also how the reporting will be goes on in the ITs, like the questions from this one. So in Indonesia, we also are developing the Wi-Fi TB. Wi-Fi TB is the application from in the Android. So the private practitioners, especially from the doctors, will be can be easily to report the TB patients. So it's developing. In the first version, still need a lot of what we call data to be filled, but nowadays we want to have a more simple, like for example, maybe we can just take a picture for the ID of the patient, and then we can put, so the idea is we want to make the medical practitioners as very simple information to send. And the second, we want nowadays we also in the process of integrating the hospital information system with TB information system. So it means that once hospital input the data of the patient and the codification of the TB is mentioned in that hospital information, so it will be linked to the TB information system. So we want to make it as simple as we can to help the hospital or private providers to get involved to the TB program. So that's the idea, Williams. Thank you.
Great. Thank you so much, Pak Imran. I think this is a perfect closing point for this session. It's been a very, very rich session. I think what Pak Imran just mentioned is really a real world example of what Dave Clark was talking about in the beginning, which is a public sector that understands how it needs to reach out to private providers and to be realistic with private providers. Yes, the TB world has certain demands, but those demands have to be reasonable and to accommodate the realities of what it means to practice in the private sector. So I think each country is going to have its unique mix of regulatory versus incentives versus kind of the helping hand of intermediaries. There's no one answer here, but we've seen a nice mix in the different countries of these different approaches. And I think also Pak Imran's final comment and a number of the comments really demonstrate that this is an area where TB needs to and is reaching out to other parts of the health system. So the only way we make this work is to reach out to the insurance system for payments for clinical care, to the Ministry of Planning for these kind of minimum requirements that are pushed down through the planning system. So there's many ways in which we need to engage outside of TB, and that's how we make PPM a success. So thank you to all the panelists for all your time, both today and during the recording sessions. Really appreciated, and I think this was a very interesting panel. So back to you, Monica. Thanks again.
So thank you very much, William. Indeed, it was very rich discussion, excellent moderation, and indeed we could see examples from our champions, not only representative of the high burden countries, but also the strongest, the best experienced heads of the TB programs in the countries, and it was really deep diving. Of course, countries are different. There is specificity. There are some problems, but we can learn from each other, and this experience sharing best practices will be extremely helpful. Of course, despite of numerous problems, we can somehow summarize the main challenges. Of course, how to motivate, integrate different care providers. Second thing, how to provide quality of care. And another question is how to build sustainable legal mechanism and funded mechanism for the engagement of different providers in TB care. So all these questions are here. We made a lot of work during these years, and now I think it's time to receive some impact and benefit from our experience and capitalize on it. So excellent, very impressive discussion. Now I would like to invite Petra Heidkamp from McGill University, who manages the PPM Learning Network. Remind you, this excellent initiative was launched in Hyderabad at the Union Conference. It's been a year when we marked the first anniversary of the Learning Network. Petra, can you please provide us with an overview of the progress? And we know that it was a really excellent, one of the brilliant initiatives, and we've already all benefited a lot from it.
Thank you, Teresa. Yes, I'll happily share. I'm going to put on a presentation, and I hope you can all see this. Is it visible? Yes. Okay, yes, so let me follow up straight where you ended, Teresa. Thank you so much. This is an image of all of us together last year in Hyderabad during the PPM working group meeting, where I had the pleasure to really launch with you all. You launched basically the TB PPM Learning Network. So the PPM working group has been already working for so many years, and as you have heard this morning, so many different examples. And what was felt, the reason why the Learning Network was launched was to have an opportunity to continue discussion during the actual year, not just in the meeting itself, but create a platform online so that people can discuss more and learn more directly. So to get you all together on the same page, what we launched as the vision is very much what was discussed just recently: quality TB care for all people by all providers. And the mission of the Learning Network really is to have an active debate, a place for South-to-South exchange, to share best practices, share expertise, learn from each other on things that work and things that don't work, and in that way really to have a larger base of knowledge. So our objectives are really to look at the knowledge. How can we understand what is happening and what needs to be addressed? How can we ensure that there's expertise coming to you through webinars, through forums, through material, through information? And how can we pull the learning in? So what is happening on the ground is often not documented. So we're trying to help document stories from the front line and make sure that the country experiences are really being brought more to the front, and that there's an opportunity to exchange. So we're in the network trying to offer platforms for active engagement with one another, or even a country matchup in lessons learned. And all of that, we hope that also helps towards giving more profile towards private sector engagement and PPM in general within the TB community, but also beyond the TB community. So this is where I don't expect you to read all the words. It really is to give you an overview of the building blocks of how we started last year. We thought the first step really is to build the community. We are starting with the PPM working group, but we want to reach beyond it and really have everyone who is interested in this topic and interested in TB join and have an opportunity to learn together. Find mechanisms, a website to maintain the community, and then obviously look at ways to measure this. So to look at the building of the community, immediately in Hyderabad, it was already clear that there was a lot of enthusiasm. And within the first several days, many people joined the platform that we had created. Today, I'm happy to show you that we have a map where individual members are being visible. And the 7 countries that have been talked about today a lot are very well represented in the top 10. And we have a large representation around the world. Just to show you the membership growth, within the first 50 days, we already had 350 members, and within the first 100 days, 500. As of today, we have passed 1,300 members, so within the first year, we've really grown rapidly. To show you a little bit of our governance system, we have a steering group that guides us with the overall themes and direction in what the different topics are that we are looking at and the way we're organizing ourselves. And we have an expert panel with people from around the world that have been providing input in webinars, helping us with documents, collecting resources and putting information together. And that's supported by a team that is now growing. We're really pleased that we now are starting with a special project within India, and you'll be hearing soon more about that. So to give a little bit of a background, the Learning Network itself is using an online platform, and we offer 2 ways of organizing the information. We have a learning section where you will find lots of resources, which is basically like an online library with course material, with anything that is relevant to PPM. Then we have done webinars, and we will go a little bit more into detail, and feature stories, the same. We have a COVID page with a lot of resources and material on COVID, and a forum. Now, all of these also give you an opportunity on our platform to interact. So there is an active interactive feature with a live feed, like many of you might be known with a Facebook chat. So the similar feed like that is available on our site. And we use different communications tools to reach out and make sure that all the members are connected and updated on what is new. There's a weekly digest that goes automatically to all members. And we do bi-monthly newsletters where we highlight some of the key activities or the key news. And we use the different social media tools where you can tap into hearing what the news or the latest updates are. To show you the TB webinars, I really enjoyed listening to the panel discussion with all the country members, and it really made me think of the many webinars that we've done over the last year. We've organized 16 webinars in the first year, and the webinars were set out with 2 main topics. First of all, to have learning on the PPM strategies and really push out more information on the PPM roadmap and how countries can practically engage with the roadmap. And secondly, to build up practical experiences from the ground. Well, we had lots of interest, over 4,500 people registered ahead and more than 10,000 viewers on our YouTube channel and on our platform directly. And I just want to highlight that obviously with COVID and the pandemic this year, that was not directly maybe in the first instance related to what we set out on the PPM roadmap, but it has really been an opportunity for the Learning Network to bring the TB community together. And we've used the platform to have discussions on COVID. And we've seen a lot of interest. And so this little graph is showing you the registration and the attendance. And the yellow line is the questions and answers. And just to show the peaks were all around COVID discussions. So there was a large interest in discussing within the community. And we had over 100 questions and answers during some of those sessions. To highlight some of the feature stories, this is something that we've developed recently and felt was really important because, as you heard in the recent panel, there are so many developments happening on the ground that are good for others to hear about. So Dr. Adebola mentioned the Maths app, and that is one of our feature stories by chance. So we're doing 2 feature stories per month. And this is where members are collecting information, and you can also see short interviews with the different authors of the feature stories on our YouTube channel. Now, how useful is any of these? We've done a survey amongst all our members in the last month and got some feedback. It's not a very clear graph, sorry about that, but the yellow bars show you that basically everything that we offer is seen as useful. And the most useful are the resources, the webinars, and the feature stories. The green is what is not useful. And I'm pleased to see that the job section is the area that is the least useful, and that is logical because a lot of people might be happy in their steady job and find that not useful. So overall, this is really great feedback for us to hear that the various sections are being seen as useful. So to go on back on the survey and give you one more graph, how does the community engage? We wanted to get an insight from our different tools that we offer, and we're pleased to see that people really like the weekly digest and the way of updating on a weekly basis, that their email reach is the way that people actually communicate more than, for example, the social media, which is the bottom bar. We see that that is less often a way of interacting. And overall, 78 people think that the TB PPM is worth their time, which is a great way of measuring your interest. I wanted to highlight also that we've been, as our platform, we've been heavily involved with the civil society and community groups that have collected data on the ground on how COVID has impacted their situation. And the PPM Learning Network offered a platform to help with the data analysis and really pull the different information together. So it's been a really great experience and a way of pulling community groups together. In our first year, we've had many of Madhu's wonderful articles in the Forbes help put information out that we could follow up with webinars or with specific information, and it has really helped to pull the content of our information together. So I wanted just to show you that there are some articles where we have pulled already resources that we have collected in our TB and COVID tracker into an academic article. And that way we're trying to synthesize some of the information that's relevant. And we will be looking forward next year more toward providing on the specific topics relevant to PPM to provide more data. Lastly, I wanted to draw your attention to our annual report. You can all download or view it online, and I will happily share the details in the chat later on. This is where you can read all the different information that we've done this year, and you will also be able to click within the links to our different resources directly on our site. So I want to finish by thanking everyone. I want to finish by thanking the PPM working group for launching this wonderful initiative. I want to thank the steering group members, the expert panel members for their enthusiasm and support in the first year, and all our partners. And lastly, I want to thank all the members, because thanks to you, this is actually working, and we can see that it is very encouraging to see all your ideas and support and your interactions online. And so if anyone on this call is not yet a member, please feel free to join. Thank you very much. Over to you, Monica.
Thank you. Yes, thank you. Thank you very much. Thank you very much, Petra. It is really exciting. And congratulations to you, to Madhu, to our colleagues from Bill and Melinda Gates Foundation. A very promising initiative, and I hope that we will receive much more impact from this, and it should be continued definitely with our all close engagement. I was personally also happy to be part of your interactions. I know that Monica spent a lot of times. It's really a good platform for engagement of all partners and stakeholders. So excellent. So it will be, by the way, interesting to know how many private care providers joined to this. If you will give this disaggregated information, it will be interesting how we're succeeding with their engagement in this platform. So thank you very much. Time is running so fast, despite of numerous interactions during the year, this learning other platforms. You see, we need much more time, probably more regular meet to exchange our thoughts and experiences. So I would like to move to, we are close to the end of today, but we have a few more very important interventions. And you know that this week is also marks a World Antimicrobial Awareness Week. And of course, it's important time, and we have multi-drug resistant, probably major contributor into this broader AMR agenda. So that's why we should also highlight, use this opportunity and attract attention to the problem of people with drug-resistant TB. And today we're also pleased to have with us colleagues, our young colleagues from Vietnam. Dr. Thuong is a member of Vietnamese National TB Research Network, Victory. She is the vice president of the Vietnam Youth Society to End TB and part of WHO 1+1 Youth Initiative to End TB. She and Dr. Hai Nguyen have prepared a special video for us. Following, she will provide her intervention.
Em tên là Vũ Hạnh Ngân, em 15 tuổi và học ở trường Trung học phổ thông Sóc Sơn. Em bắt đầu ho từ đợt tháng 6 năm 2019 để kéo dài đến tận tháng 1 năm 2020 để em vẫn chưa khỏi. Khi em có những triệu chứng ho kéo dài và sụt cân thì em đã đi khám tại bệnh viện đa khoa trước, thì nghi là em bị nhiễm Covid. Sau đó thì người ta chuyển em đến bệnh viện phổi trung ương. Em được chẩn đoán là loại lao kháng thuốc. Lúc đầu thì em nghe thấy bệnh lao thì em vẫn chưa hình dung rõ nó là cái bệnh như thế nào. Khi giờ giải thích thì em biết được đấy là con vi khuẩn nó ở trong người. Khi vừa sinh ra thì mình được tiêm phòng chống rồi, nhưng mà nó vẫn ở trong người mình. Nhưng mà người nào mà có cái đề kháng kém thì nó sẽ tự phát sinh ra. Còn những người nào khỏe thì cái đề kháng có thể tự chống lại con vi khuẩn này. Khi nghe tin em bị lao thì bố mẹ em cũng khá là sốc. Nhưng mà sau khi được bác sĩ tư vấn thì bố mẹ em cũng bớt lo hơn. May là mình chỉ mắc lao vẫn có thể chữa được. Cái loại lao này có thể lây nhiễm với người khác, nên là em chú ý đeo khẩu trang thường xuyên để tránh người khác bị lây bệnh. Phác đồ khá là dài, 18 tháng. Lúc đầu em nghe em sợ lắm, nhưng mà xong nghĩ là vì sức khỏe để không ảnh hưởng đến cái phổi bên kia thì cũng nên chịu khó uống thuốc đúng giờ. Hầu như hôm nào uống thuốc xong em cũng cảm giác bụng cồn cào, khó chịu, chỉ muốn nôn ra. Nhưng mà em cố. Mỗi buổi sáng nghe chuông báo thức dậy là không muốn dậy, em quá mệt. Đợt đấy em một tuổi em không thi được lớp 10. Sau vẫn phải cố uống thuốc, vẫn đi học với các bạn. Về thuốc em được cung cấp miễn phí bởi chương trình chống lao quốc gia. Nhưng mà trong thời gian điều trị kéo dài thì em phải đi tái khám nhiều lần. Điều đó ảnh hưởng đến thời gian và kinh tế của bố mẹ. Mỗi khi mà em có ý định buông bỏ thì điều giúp em tiếp tục uống thuốc để khỏi bệnh là một là sự tận tâm của bác sĩ, hai là sự chăm sóc của người nhà, bố mẹ em. Với cả em nghĩ đến tương lai sau này là được đi chơi vui vẻ với các bạn, học hành. Phác đồ trước là 9 tháng nhưng mà lại còn 4 tháng tiêm nữa. Phác đồ mới thì em bỏ tiêm. Thuốc thì viên thuốc nó ít hơn, nó nhỏ hơn nên là em thấy dễ uống hơn. Trước khi được điều trị thì em thấy hôm nào nó cũng rất là mệt mỏi, khó chịu, chán ăn. Hiện tại thì em đã được điều trị đến tháng thứ 6 và sức khỏe của em bây giờ thì đã tốt lên khá là nhiều. Em đã tăng lên được khoảng gần chục cân. Các bạn trẻ khi có triệu chứng như là ho, sốt kéo dài hoặc là sụt cân thì nên đến các cơ sở y tế chuyên khoa để phát hiện bệnh sớm này, được điều trị kịp thời. Mắc bệnh lao không hề đáng sợ, nó có thể chữa trị hoàn toàn nếu người bệnh phát hiện sớm và được điều trị đúng lúc, từ đó sẽ giảm nguồn lây cho cộng đồng.
It was very, very nice video. But by the way, also participated in your marathon. It's a very good movement. I was proud to be part of it. Dr. Tiong, now floor is yours.
Hi everyone. My name is Thương from Vietnam NTP, and it's my great honor to me to be here. And today I'm going to talking about PPM and drug-resistant TB in Vietnam. Can I share my screen? I have some slides and share some information with you all.
I forgot. Yeah.
Hold on, we are opening it, Thuong.
Yeah. Hello, can you hear me? Hello?
Yes, well.
Yes, we can hear you.
Yeah.
Just
so,
give 1 minute.
Yeah.
Go ahead, Thuong. We can see the slides.
Yeah. Please, next slide, please. So today I want to, according to the Global TB report, Vietnam is still among 30 high MDR TB burden country and strong, and also have a strong, very strong and complicated private healthcare sector. In 2019, nearly 3,500 MDR TB patients was notified, account for 3.6% of all new TB case. Next, please. In Vietnam, we have three form type of PPM model in which the private sector need to prefer presumptive TB patient to the NTP or diagnose them first and then refer them to the NTP for treatment. The next level is to engage in DOS, and finally, the private sector would diagnose and treat TB patient like a TB unit, and annually PPM contribute 10 to 30% of TB case detected. Next, please. Next, please. Just like the girl in our video, many TB notified TB patients seek into care in private sector first before visiting NTB facility. And the girl in our video sought care in Tâm General Hospital is a private hospital in our PPM network and got the charity grade. The doctor saw inmates suspected of TB and refer her to the NTB of the National Lung Hospital. In our hospital, her sputum sample was tested and she was diagnosed with MDR TB and treated here. However, she was among only 57% of incident TB case that was known to the NTB. The rest of them may have received care in the private sector. And nextly, in the last one, I want to emphasize that PPM is highly essential for MDR TB treatment and management. Firstly, TB patients without adequate care may develop drug resistance. And in my research in Hải Phòng, we found out that with digital monitoring system and PPM efforts, we can successfully treat 92% enroll TB patients. In Vietnam, especially in southern areas, many people prefer private sector because it's convenient. So PPM effort could ensure that MDR TB patients receive a maximum care. And the last by notifying the NTP about their MDR TB patient, the private provider contribute greatly to the monitoring of MDR TB. Thank you so much for listening.
So thank you very much, Dr. Tung, and your colleagues. Dr. Noon is joining us too for a few comments. So nice to see you.
Hi,
nice
everyone.
to see you. Yes.
Sorry, I'm on a mission today, so I'm not in my formal clothes yet.
So, but it's good to.
It's really great to be here with you.
So,
and yeah, please go ahead. Sorry.
No. Please just say a few words. I know that you are very enthusiastic. They're working together. You are doing excellent teamwork, and please continue. We'll be looking forward to hear more from you.
Yes, thank you. And it's really our pleasure to work with everyone, and it's because it's a short notice, so we couldn't do anything more than that. But really, in the future, we really want to collaborate with the WHO more, and we want to produce more of the great stories in Vietnam.
So absolutely, it was very interesting story, and I've heard also one interesting moment fixed from this video and your presentation, that there could be also several different levels of engagement of the private care providers. They could be proposed like different options. Either you are referring immediately to the public sector, either you are providing diagnostics, or even going deeper. So this could be also very interesting to explore how it will work in practice. So great, please continue. So thank you very much, and now we are almost there. But first, I would like to propose and to give floor to my another young colleague, Anna Stukalova, and she will introduce pre-launch of the updated landscape analysis of private sector engagement that we're planning to launch later on this year.
Thank you, Teresa. Hello, everyone. My name is Anna Stukalova, and I work in WHO Global TB Program. And I'm very honored to join you today for my first PPM working group meeting, and I hope not the last. And I'm pleased to introduce you the pre-launch of the landscape analysis on private sector engagement to NTB. We are now in the process of finalizing a 2020 update. Here's, Monica, please. Yes, here's a quick outline that has been worked by WHO with the PPM working group, leadership, USAID, Gates Foundation, PPM Learning Group, Global Fund, Stop TB, and countries. There are 4 main sections. First is introduction with background, latest data, published evidence, evolution of guidance, and work of key partners. Second is progress in uptake of the PPM roadmap. Newly launched PPM Learning Network, and work done by WHO UHC Department on Private Sector Engagement. The second section is on challenges with new information on COVID-19. Third one is country experiences from big 7 countries and additional ones. And thank you to all the countries for doing the review. And the last section is outline way forward. Now I would like to invite you. Invite you to participate in one activity and invite following people for the pre-launch of the 2020 updated landscape. PPM Working Group Chair Dr. Madhupai, Vice Chairs William Wells and Dr. Lal, WHO Global TB Program Director Teresa Kasaeva and Monica DSS Secretariat, Dr. Guy Stalworthy from Gates Foundation, who was the main author of the landscape, Dr. Mohammed Yassin from Global Fund, and Jacob Criswell from StopTB, NTP managers from the big 7 countries, of course, Funke, TB Survivor, and colleagues from W regional offices. I invite you to click on the link that E just shared in the chat and open the cover on your phones, and of course put your camera on. And here's Monica is a great example of how it should look like. So the idea is that we will take pre-launch group photo. So please put your cameras on.
Did you send it?
Yes.
Links to the email.
So you just need to open it on your phone like this.
How can I open my phone?
Just click it. That's it.
So
and
we will take a screenshot of everyone, and then it's going to be another big collage with everybody's photos, a nice one. So thank you for all those who put their cameras on. And me and E now gonna make the screenshot.
Okay, so I see Madhu, you have it open. William has it open.
Yes.
I don't have it.
Here it is. There, just hold it up.
Teresa, you have it?
Yes, I have it.
Okay.
We'll take a picture of Teresa here, okay?
Yeah.
Who else? Let's look at the gallery. Wow, okay.
Yeah.
Guy, okay, good. Lal, do you have it open? It's, I WhatsApped it. You can open it on WhatsApp. Funke, do you have it? Petra?
It's downloading.
So what should I do now?
Very nice. Okay, so I see Mohammed Yassin.
Can you see me? Or no, you can't.
Yeah. Yes. Okay, Pak Imran, Bola, Dr. Levinson. We invite everybody who has video, who has panelist access to please show, and we will take snapshots.
So it's done. Thank you, everyone. And of course, we will keep you posted and share final landscape analysis once it's launched. Thank you, everyone, for today's meeting. Teresa.
Yes, thank you very much, Anna. You see, despite of some challenges and the fact that we can't meet each other in person, we have some advantages trying to use innovations and new technologies. We, of course, we can do much more, and including for the public-private engagement to be more innovative. And so we've completed our today's agenda, and I would like to give a floor to our honorable chair, the academic Madhukar Pai, for your closing wrap up and conclusion. Thank you.
Thanks, everyone. This was way better than I expected, given the online format. We are getting smarter with the use of video and recorded content and so on and so forth. So thank you so much. We had 200 people at some point or the other, which is quite an accomplishment given the online format. It's clear that we really have a long way to go to catch up on how much ground we've lost this year, and engaging all sectors is absolutely fundamental. Public sector alone cannot pull this off, simply not possible given the COVID problem that continues to play out in many countries. So we look forward to seeing you on Wednesday, where we have a lot of additional interesting content available coming to you. And until then, please stay safe and be well, and we will be in touch. Also, please join the online community that Petra shared you the link with, so that you can also see what other reports and landscapes and other things that we are producing for you. Thank you. And Monica, Teresa, Anna, and Yi, great job with all the hard work that you put in.
So thank you very much, Amadou. And we will continue our discussion. We will have opportunity to highlight some important things which we probably didn't touch today. Of course, it's very challenging time, but let's think all together how we can transform our challenges into opportunities. And you've seen already, even today, that we are championing, I mean, TB community in many things. And you've heard that we already have rich experience in the engagement of the healthcare providers, and now this experience is used by other colleagues and for the broader UHC agenda. Also, I would like you to give another example. Here in WHO, we are pioneering, piloting with a new approach for the guideline development, and now this approach is uptaken also broader. Let's try to think about new ways of highlighting importance of TB programs and our best practices and how to prioritize and not avoid any neglection of those millions still suffering and dying. TB remains the biggest infectious disease killer in the world. And it should be clear, this information should be shared with the high-level officials, and we should advocate strongly for the clear, meaningful actions. So with this, we will close our session today, and we'll be looking forward to hear from you and continue discussions the day after tomorrow. Thank you.
Thanks, everyone.
Bye, everyone. Thank you.
Okay, see you.
See you on Wednesday.